Natalie, everything all good?
Hello.
Hello,
Yeah.
it's good. Wonderful.
Yeah, it looks good. So we're just awaiting Shannon and your other moderator, Kevin Wright. So
Kevin, right.
Shannon.
Wonderful. Wonderful.
So Nathaniel did want the webinar to go live at 10:02, but we might just give it a couple more minutes to make sure your key parties are here.
Wonderful. Okay, I will go off video again. And I'll mute.
Okay, thanks for checking. Good morning, Dr. Farmer.
Good morning. Who am I talking to? Natalie, is it?
Yeah, I'm just the tech support today, wanting to make sure that everything is good from your end with your setup. Looks
Hi,
good.
Natalie. Thank you. How's the audio?
Clear, nice and clear. Same with your visual, very good.
Yeah. Hi,
Good.
Shannon. Carolyn, how are you?
Hi, Carolyn. Nice to see you.
Good to see you. So what time is it in your world?
It's 8 p.m.
8 p.m. Oh my heavens. Okay. Wow.
Yeah, so we're what, 12 hours ahead of you, something like that.
Yes. Yes. Goodness. Yeah. I'm still trying to get used to this whole concept that, we're able to do all this like this. It's just crazy.
It is incredible, isn't it? It's
Yeah,
amazing.
thank you so much for being with us. It's going to be wonderful.
Pleasure. Thank you for your invitation. Looking forward to it. I hear you've got some good registrations.
Please, Carolyn, if Kevin doesn't come on, it means you handle everything. But if you can, please give him a call to find out whether he's okay.
Okay. Yes, I'll text him right now, and I'm going to put myself on mute.
Perfect, thank you. And Dr. Farmer, so do you have a presentation that you're going to be showing during today's?
I do. Yes, I do, yeah.
Do you mind just practicing? Let me stop the sharing on my end.
Yep. So shall I share?
Yes, please.
Okay.
Perfect.
How's that?
Perfect. Great.
Good?
Thank you.
Okay.
Sometimes it's a little bit bumpy, so it's good to see it's smooth.
Okay.
Thank you.
Very good. That's great. It's always nice when technology works.
Yes. Hey, Natalie, really quickly too, I take
Yeah,
it,
please.
I am going to mention that throughout the progress of this whole session, that folks should place their questions into the chat box. Is that correct?
Correct. So let me just check on
please, it's in the Q&A.
Yeah,
Not the chat.
that. Thank you, Dr. Osoro, because that's correct. I think in the chat, only the panelists can see. So if all the attendees have questions, it has to go in the Q&A box.
Q&A box. Good. I want to be sure to mention that because yes, every time it tends to be different. So good. Now, as well, I'll mention that and say that then at the end, we'll save them all for the end. And then Kevin and I can alternate and field those for each of the speakers. So that's good. Great, great, great.
Dr. Osoro, is that at the end of the whole day or at the end of each segment? were you going to do it at the end of each segment, Carolyn?
Yeah, I can do either. If you'd like us to do
Okay.
it for each speaker, we can stop. Or we could do it all at the end, whatever. Nat, what would you prefer?
Yeah.
Sorry, what was the question?
Do you want me to do, Kevin and I, to do the Q&A after each individual speaker, or wait until the end of the whole session and field the questions accordingly?
Shannon, what would you like? Want to take some questions at the end of your own presentation?
I'm easy, Nat, whatever works best. I'm happy to take questions straight afterwards, or if it works out better to have at the end, I'm happy to do that.
Okay, so Carolyn, just measure the mood. If it looks like it's better at the end, because at the end saves time. I think it's better that way in case we're running short.
Okay, so at the end of the full session, we'll field all the
Yes, of the entire,
Okay,
yeah, the
okay.
3 speakers.
excellent.
Thank you.
That's great. Thank you.
What
I was just
time is that?
I was just going to ask that, because are all the lecturers still going to be here at the end? And also, does Carolyn know what time each lecture has to start so it doesn't go over time?
Well, I think we have more than enough time. The keynote is 40 minutes. The other speakers are 30 minutes each.
Yeah,
Just as long as it's not 2 o'clock in the morning for me, that's all.
yeah.
Otherwise, I'll take
No,
questions straight away.
the whole session is on my time, Eastern time, Shannon, it is an 8 to 10:30. So 2.5 hours. So that would be 10:30 p.m. your time. But that's why, seriously, if you need to hop off and you want to present yours, I mean, Nat, we can certainly do that.
Maybe it might be a good idea, just in case I get interrupted later,
Yeah.
if you wouldn't mind. Thank you.
So let's do that. And that's also being respectful of your time zone. And because I know Dr. Waters will be on my time zone. I believe also Dr. Jones is as well, because he's North Carolina. So we are all Eastern time here in the States. So let's do that now. Let's let Shannon take questions directly after, and that way, if he needs to mosey, or like you said, you get interrupted, you can do that.
Yeah, I plan to stay on, but if it doesn't work out, it might be safer. Yeah.
Okay, good. All right.
As long as Nat doesn't turn me off.
I know we have two Nats here. We have Nat and Nat.
Oh, that's right. We do.
Yeah, sorry. Do you have any other questions before I go live? So what I'll do is, when you're ready, I'll start the webinar and just have everyone muted and have the logo up, and then spot on the hour, you can just unmute yourself and start. Is that okay?
Fine.
Yeah, everyone good with that? Okay.
And I did text Kevin, and I've not heard back, but that's okay. We will soldier on.
Okay, well done.
Absolutely.
All right. Very good. Well, have fun, everybody. You'll do great.
Thanks, Natalie.
Thank you.
Thank you.
Natalie, please check my camera, see whether it's okay, please. I changed location.
Thumbs up. Very good. Maybe just tilt it down just a little. Excellent. Looks like everyone's here as well, and we are live.
Hey, good morning, Nat and all.
Good morning, Kevin. We are live.
Good morning, Carolyn. Good to see you.
Good morning.
Hi, Kevin.
Good morning.
So we are 8 o'clock. Should we get started? All right. Why don't we?
In 2 minutes.
2 minutes. Okay.
It's not yet 8 o'clock in Africa.
Okay.
Hi, Kevin. Good morning.
Good morning.
Dr. Sharon, good morning. Caroline, good morning.
Good
Abigail,
morning.
we're live now, Abigail. Okay, Carolyn.
Good morning. I apologize, the site kicked me off. Can you all hear me?
Yes.
Yes.
Great, wonderful. Well, we're going to get started. Good morning, good afternoon, good evening, wherever you happen to be. I'm Dr. Carolyn Burns, and I'm the current president of the Society for the Advancement of Patient Blood Management. And it is an unbelievable honor for me to be here to help moderate this opening session for not only is today World Bloodless Surgery and Medicine and Surgery Day, but this entire week is Bloodless Medicine and Surgery Week. And we have an unbelievable conference that has been coordinated with folks from around the globe. And we are going to be celebrating alongside our hosts as well, our good partners, the Bloodless Medicine and Surgical Society and the University of Calabar, who have been longtime colleagues of ours alongside SABM. And SABM is so happy to be able to endorse this program. I want to give a quick and brief shout out to our industry partners here today as well, HemaQ as well as EcoMed. And then before we get started, introducing our speakers and going live with our sessions, I want to turn the floor over to Dr. Osoro, who's part of the Bloodless Medicine and Surgical Society, and he wants to provide a few words alongside his colleagues there in Nigeria. So Nat, I'll turn it over for you, and then we'll get started with our speakers.
Thank you very much, Carolyn. It is indeed a great privilege for me to be welcoming you all, an international audience indeed at present, to the World Bloodless Surgery Day and the Bloodless Medicine and Surgery Week 2022. Bloodless medicine and surgery is the provision of quality healthcare, medical and surgical, to a wide variety of patients without the use of allogenic blood or donor blood, with the aims of improving clinical outcomes and protecting patients' rights. It all started with protecting patients' rights because some patients would object to blood transfusion. And so some clinicians decided that they have to figure out how to care for these patients. One of such notable clinicians was Dr. Denton Cooley, who is widely regarded as the father of modern bloodless surgery. It was thought at the time that bloodless surgery was impossible in the area of open heart surgery, where they use 20, 30 units of blood. That's what they used to do. But Dr. Cooley figured out how to do it completely without blood transfusion. Moreover, he recorded better outcomes. The World Bloodless Surgery Day was instituted in honor of Dr. Cooley's work. And May 16 is the day that Dr. Cooley performed his first bloodless open heart surgery in 1962. Our keynote speaker today is going to tell us much more about this, so I won't say more. Dr. Cooley published his work showing improved clinical outcomes, like we mentioned, with his bloodless surgery. And several other workers since then have published similar improved outcomes with bloodless surgery. None has had a worse outcome because of doing bloodless care. So the emphasis has gradually shifted from the advocacy, from protecting patients' rights to improving clinical outcomes. The World Health Assembly in 2010 came out with resolutions to promote patient blood management for the first time. What is patient blood management? Essentially, it is bloodless medicine and surgery, given another name. Last year, 2021, the World Health Organization issued a policy brief, again, exhorting all clinicians to embrace patient blood management. And again, the emphasis was on improving clinical outcomes. The purpose of the Bloodless Medicine and Surgery Week is to raise awareness about the vast potential for improving clinical outcomes and protecting patients' rights by employing bloodless medicine and surgery techniques. We started the Bloodless Medicine and Surgery Group in the University of Calabar in 2007 with just a handful of clinicians, multidisciplinary group. And it was initially just a clinical practice. But education is fundamental to the practice of bloodless medicine and surgery. And so we began to have one-day seminars about 2009. We first held a one-week educational event in 2016 with inspiration, I must say, from Professor Xavier Sola, the professor of surgery in Spain, who was holding Bloodless Medicine and Surgery Week during the last decade. I think he himself will be here to share some thoughts. And so we started in 2016, and in 2020, because of the pandemic, we moved online, which turned out to be quite a blessing because we could increase the participation of both speakers as well as attendees. This year, a world-class panel of experts will provide education on how to achieve bloodless care in maternal and child health. We are very thankful to our speakers who are donating their time and energy and other resources to provide this valuable education to the world at no charge. Many of our speakers are true heroes, and some of them may come to mind in this regard, like Dr. Shanda, who has been featured in Time magazine as a hero of medicine, was featured on the cover. But today I have to mention another hero, one of our speakers today. He was just discharged from hospital 8 days ago after suffering a large hemothorax from trauma with rib fractures requiring chest tube drainage. Yet he determined to make this presentation because bloodless medicine and surgery is so close to his heart, and he values you all in the audience. I'm referring to Dr. Jonathan Waters, Professor of Anesthesiology in the University of Pittsburgh, who is going to be our last speaker for today. Thank you very much, John. We're also thankful to the moderators and panelists, many of whom are in the Bloodless Medicine and Surgery Society Conference Organizing Committee, including, of course, the SABM President, Dr. Carolyn Burns. I cannot mention all the names, but many of them are here. And without them, we couldn't have put this program together. This meeting, as you may have noted, is a collaboration between the Bloodless Medicine and Surgery Group in the University of Calabar, Nigeria, the Bloodless Medicine and Surgery Society, and the Society for Advancement of Patient Blood Management. So we are very thankful to all these organizations. Our home institution, we are very grateful to the University of Calabar, and especially to the Dean of the Faculty of Clinical Sciences. That faculty is hosting the Bloodless Medicine and Surgery Group, and is also hosting the Bloodless Medicine and Surgery Society, because I happen to be the current president of that society. The Dean intended to be here to say some words to us, but apparently he is still in transit because he traveled. I guess whenever he's able to connect, he may have opportunity to speak to us. However, we have here with us still some notable individuals from our institution. One of them is someone that we refer to as our grand patron, and is also a life member of the Bloodless Medicine and Surgery Society. He is a former provost of the College of Medicine in Calabar, and the former chief medical director of our institution. And he's a retired professor of obstetrics and gynecology. So this is what we are handling today, is squarely in his area. I'm referring to Professor Itam Hogan Itam. And please, I will pause here at this point to allow him to say a few words. Professor Itam, please. Okay, so while he's resolving his challenges, Professor Roland Ndomaegba is here, and we would ask him to please say a few words. Professor Ndomaegba was also the previous chief medical director of my institution. He was my teacher. By the way, all these two gentlemen were my teachers. And I also served as his house officer and resident. And he is also a life member of the Bloodless Medicine and Surgery Society and the patron of the Bloodless Medicine and Surgery Group. Professor Ndomaegba, please.
Thank you for asking me to say a few words. I feel honored to be here. I'm glad to note the tremendous achievements the Bloodless Medicine Society has scored over the years. I'm glad to be here, and I'm sure it will be a very successful conference. I thank all those who have come, and I'm sure that we'll enjoy the occasion. Thank you very much. Thanks for having me.
Thank you very much, sir. So we also have here somebody on the side of SABM, and he's also on the BMSS side. He's a member of both, and one of the leading lights of Bloodless Medicine and Surgery from Johns Hopkins. He has been speaking several times on this, but today he's here as a panelist. And I'd like to bring him in to say a few words. That is Dr. Stephen Frank, who is a professor of anesthesiology, and he's also the director of the Bloodless Medicine and Surgery program in Johns Hopkins in Baltimore, USA. Dr. Frank. Okay, I'm afraid. Okay, Dr. Frank is coming on. Hello, Steve, are you there? All right. Steve is a very busy person and he runs an extremely busy practice. So maybe he will speak later when he's a bit free. So I cannot end what I'm saying without thanking the attendees who are here. I want to thank you very much because without you, we couldn't have this meeting. And the technical support, Natalie, Eric, the Scene Lab group who have been supporting our conference, helping us with the technical aspects, and UD, who has been virtually organizing everything and putting out the flyers and posters and stuff, which has made it possible. She's also handling our Facebook page. Our webmaster, Folusho, and many other individuals who work together to make this meeting possible. So I thank you all very much. Oh, Dr. Ago is here. Dr. Ago is our deputy dean. I think I was told that if the dean cannot be here, then Dr. Ago will represent him. So please forgive me. Let me see how we can make him to come up as a panelist. So Dr. Ago, I think I've moved you to panelists, and you can unmute, put on your camera if you wish, and speak. Dr. Ago is an associate professor of obstetrics and gynecology. So again, this is squarely in his field. He's also a member of the Bloodless Medicine Surgery Group in the University of Calabar, as well as the deputy dean. And by the way, the dean is a founding member of the Bloodless Medicine Surgery Group. So it looks like we're all family here. Dr. Ago, please go ahead.
Okay. Thank you very much. It's my pleasure to be here. The Dean, Professor Ngim, sends his apologies. He had to travel. Being in transit makes it impossible for him to join. But he sends all his goodwill. And just as you have said, this program is very dear to him. And the faculty also sends their well wishes. It is our belief that as you have chosen our own side of it, that is talking about me here now, obstetrics and gynae, we try as much as possible to maintain bloodless medicine. As a matter of fact, obstetrics is a very bloody practice, but with the advent of evidence and skilled changing practices, we have seen a revolution, as it were, in the practice of bloodless medicine in obstetrics and gynecology. So I welcome you all, and on behalf of the dean, wish you a very fruitful deliberation. Thank you.
Thank you very much, Dr. Ago. So thank you, everybody. And I will now hand over back to the moderators, Dr. Burns and Kevin.
Great. Thanks, Dr. Thoreau. Thank you for everyone who's logging in. I'm sitting here watching the numbers. It's pretty exciting. We have 270 people on right now and still people coming into the room. So a wonderful participation. And I'm just really excited to be a part of this. And before we introduce our speakers, I do also want to introduce my illustrious colleague, Mr. Kevin Wright. Many of you know Kevin because he's been a long-standing member of SABM. He is our current newsletter editor. He also has been a huge motivator and worker bee in the area of transfusion-free medicine. He's in Rhode Island with Lifespan and has just been a great friend and colleague. So alongside Kevin, we're going to be introducing each of our speakers. One quick housekeeping item. We are going to have Q&A directly after Dr. Farmer's talk. And because of his time zone difference with us, he hopes to be able to stay on till the end, but just in case we are interrupted some, we will take questions after his keynote. Please put those questions in the Q&A, not the chat, but the Q&A. Then our other two speakers, Dr. Jones and Dr. Waters, we will hold questions until the end of the session. For those of you that are in the United States, that will be around 10 to 10:30 Eastern time. So wherever you are, thank you for joining us. Kevin, would you like to say a few words before I introduce Dr. Farmer?
Yes, thank you, Dr. Burns. Nice to be with everyone today. I'm watching the numbers go up as well. We have individuals from all over the world, and we want to extend a warm welcome to everyone. It's been a delight working with Carolyn over the years, Nat and I as well over the years. I'm seeing some members from the hospital information services from different branches, also hospital liaison committee members from different branches. So we want to welcome you, dear members, as well. There's much concern and much information on blood avoidance, blood conservation, bloodless medicine and surgery. And so I know that we'll all enjoy the program today, and it's just nice to welcome everyone. So I'll turn it back over to Dr. Burns, and we will move along and start welcoming our presenters this morning. Thank you all, and let's all enjoy the program.
Absolutely. Thanks, Kevin, very much. Okay, so for the first, I get the honor of kicking this session off with our keynote address. And this is Dr. Shannon Farmer. Many of you know Dr. Farmer. His official title is that he's the Honorary Research Fellow, Department of Haematology, Royal Perth Hospital, Western Australia, Adjunct Senior Research Fellow, Medical School, Division of Surgery, Faculty and Health and Medical Sciences, the University of Western Australia. I think we all know Dr. Farmer in our world as a leader and a pioneer in transfusion-free medicine, as well as comprehensive patient blood management. He, along with all of his colleagues at Western Australia, have really led the charge and have shown in many of their publications that, as Dr. Osuro said, this isn't just about not using blood, it's really about patient outcomes. And Dr. Farmer has recently been a part of the policy brief. As Dr. Osuro mentioned, he was on that group with the WHO that really pushed that envelope for that WHO policy brief, the guide for implementation of PBM around the world. So PBM is becoming the international global standard of care. We all have read his numerous publications. He also, I have to just tell you, is getting ready to put out another book this year, which will come out in the fall, and we look forward to having that. As mentioned, he's been near and dear to the hearts of all of us in SABM, has been a prior Kathleen Sasma Award winner with us. So he's going to be talking to us about World Bloodless Surgery Day, celebrating excellence and innovation. So with that, Dr. Farmer, I pass the baton to you, and we will talk with you at the end for questions. Thank you so much for being with us.
Well, thank you very much, Dr. Burns, for that very, very kind introduction. It's a great pleasure and privilege to be invited to speak to this group. I've been asked to speak about celebrating excellence and innovation on this Bloodless Surgery Day. First of all, my disclosures. As Carolyn mentioned, I'm on the World Health Organization External Steering Committee to develop a global guide for PBM implementation, a WHO guide. And since 2008, I've been on the Australian National Blood Authority and the Australian Jurisdictional Blood Committee working group and CRG in developing evidence-based patient blood management guidelines. Seeing we're talking about excellence and innovation, it'd be good to actually define these terms. Excellence, so one of the definitions is the quality of being outstanding or extremely good. Innovation has been variously described as creativity is the ability to create new and potentially valuable ideas in any activity. Innovation is the process of transforming these ideas into reality, testing, measuring, learning, and sharing. Innovation is the creation, development, and implementation of a new product, process, or service, and note this, with the aim of improving efficiency and effectiveness. Well, here are two men who exemplified excellence and innovation. Most surgeons will know of these two men, particularly cardiac surgeons, Dr. Alfred Blaylock on the left and Vivian Thomas on the right. They did groundbreaking research in the causes of hemorrhage and traumatic shock. Dr. Blaylock graduated at Johns Hopkins, and was there he met another innovator and proponent of excellence, Professor William Halstead. He was one of 4 founding professors at Johns Hopkins, and one of those being another innovator and proponent of excellence, Professor William Halstead. William Osler, or Sir William Osler, also referred to as one of the fathers of modern medicine. Now, all of these men made contributions to bloodless medicine surgery. How so? Well, Vivian Thomas, who was not a doctor, he was a young carpenter with a brilliant mind, brilliant hands, and love for medicine. And he, along with Dr. Alfred Blaylock, developed these surgical techniques to repair tetralogy of Fallot, or what was called the blue baby syndrome. This procedure is known as the Blaylock-Thomas-Taussig shunt, named after Blaylock, Thomas, and the cardiologist, Dr. Helen Taussig. So amazing is this story that a movie was made about it, an HBO movie entitled Something the Lord Made. The title draws from something that Alfred Blaylock said to Vivian when he observed the nearly undetectable suture line in one of the surgical procedures or techniques that he developed. And he said, "Vivian, this looks like something the Lord made." It exemplified excellence and innovation. The movie is described as an enlightening, emotional story of 2 men who defied the rules of their time to launch a medical revolution, a breakthrough that changed the face of medicine, a partnership that broke the rules. Does that sound familiar to what we're celebrating today? Here's the photo of them performing the first repair of tetralogy of Fallot. So here's Dr. Blaylock here and Vivian Thomas here. And many view this as ushering in the modern era of cardiac surgery. But who is assisting here? Well, someone we all know of very, very well, Dr. Denton Cooley, one of my earliest inspirations for my medical career. I had the great privilege of meeting him, and I was invited to host him for his receiving of the SABM Presidential Award in San Diego in 2003. Of Vivian Thomas, Denton Cooley said, even if you'd never seen surgery before, you could do it because Vivian made it look so simple. That's what I took from Vivian, simplicity. There wasn't a false move, not a wasted motion when he operated. Excellence in his hands. Cooley was highly awarded and regarded for his excellence and innovation. But Dr. Cooley had amazing insights. He was a visionary. He observed things that we're only beginning to understand now. My colleague, Professor Axel Hoffman, and I had the privilege of organizing to interview Dr. Cooley at the Texas Heart Institute that he founded when he was 92 years of age. And I'd like to actually play excerpts from this intriguing interview with him that really highlights his innovation and his observations that we can still learn from today. One of the first ones was the impact of Blaylock on him. Let's have a listen.
Well, Dr. Blaylock was an inspiring figure for me. He was more or less my role model in those early days. And I know that at the time when I was an intern at Johns Hopkins, my first assignment was to run the blood bank. and which I did for about 6 months. But some of my opinions about the use of blood transfusion began that early in my career.
So obviously innovators inspire innovators, and it does highlight the need for mentoring for future innovators. But what were some of the opinions that he developed about the use of blood transfusion early on? Let's have a listen.
I've always been rather skeptical about the compatibility of transfused blood with the recipient's blood. Well, it seems to me that the surgical profession and the medical profession too has always felt that the blood transfusion was just a simple sort of a medication or a measure that had no side effects. But in those days, it was my impression that blood transfusion was another organ transplant, and that the same rejection factors affected the blood as a transplant as would if you had a kidney or a lung or liver transplant.
So Cooley saw blood as an organ. Well, we understand more about this now. The microcirculation with its endothelial lining and the blood it envelops has been described as the body's largest integrated functioning organ system. Those in the field of proteomics have suggested that red blood cells collectively be classified as an organ because of the multiple functions they perform. About 3,000 proteins have been identified within each mature red blood cell. And as we can see here, there are multiple roles, functions of the red cell beyond gas exchange, including vasodilation, system metabolism, detoxification, and importantly, immunomodulation and cell crosstalk, cell signaling within the red cells and other cells. There's something else that another innovator, Professor James Isbister, commented on in 1978 when he said, blood is a remarkable juice, but this is only true while it is circulating within the living organism. So we know now that when blood is removed from its natural environment and placed in a foreign environment in isolation, it undergoes change. Most are familiar with the storage lesion, but there's really a collection lesion. There's a storage lesion, and there's a transfusion lesion at the point where it's transfused. And at each of these steps, there are multiple changes that take place. Some of them take place within minutes, others days to weeks. And so there's a lot of literature showing the changes that take place and the possible clinical consequences of this, including the pro-inflammatory and immunomodulatory effect of transfusion. This interesting study published in Transfusion showed that biological aging varies from donor to donor, and red cells from some donors age and deteriorate much faster than others. Red cells from some donors at the end of storage are biologically younger than those from other donors at the beginning of storage, and vice versa. This has implications for transfusion. Red cells are also large reservoirs of cytokines. This study identified 46 cytokines in red cells. That's many-fold higher than the plasma concentrations. And they highlight that these cytokines may be shared in mechanisms that are independent of hemolysis. So this too has implications for the adverse inflammatory immunomodulatory processes that follow transfusion. So what Cooley was seeing, we're getting a better understanding of, and there's a large body of literature now showing a long list of adverse outcomes associated with transfusion. And these associations are dose dependent. This shows some of the studies in trauma and critical bleeding, critical care, cardiac surgery, and other populations, very large numbers included in these studies. There's a consistent picture here that there's a dose-dependent relationship with transfusion and these adverse outcomes. So with every unit transfused, it increases the risk of these adverse outcomes. And similar results have been seen in studies looking at the impact of plasma and platelet transfusions, and again, a dose-dependent relationship. The outcomes of transfusion in cancer surgery have been studied extensively. So here's a list of some of the studies that have looked at this, the systematic reviews and meta-analyses of these studies. Here are the cancer types listed here. You can see the number of studies of the patient population. And again, there's a consistent picture here of increased mortality, overall mortality, increased cancer-related mortality, increased cancer recurrence, decreased disease-free survival, and increased postoperative complications, including infection. So Dr. Cooley saw these complications from an organ transplant very early on. We understand them better, but Cooley also came up with solutions to these problems. Here's one problem that he was working on very early on, where they saw complications associated with priming the cardiopulmonary bypass with allogeneic blood.
In the early days of cardiopulmonary bypass, that is open heart technique, using a pump and oxygenator, I was having difficulty in getting animals, maybe dogs, to survive cardiopulmonary bypass. I had been interested in some early reports about the question of compatibility of blood, particularly pooled blood. And I found that I had difficulty getting an animal to survive cardiopulmonary bypass for 30 minutes to an hour, and decided to try to not use blood to prime the system. We began priming the system with glucose solution, and the dogs tolerated the cardiopulmonary bypass quite satisfactorily. So I thought that now was the time to test this concept in patients. And when we then began doing cardiopulmonary bypass, priming this system with glucose rather than a pooled set of transfusions, we found that the results were much more favorable than it had been when we were using 6 to 8 units of blood in a pool to prime the system. That in the earlier days,
Dr. Cooley was presented with another problem, or rather a challenge, and that was patients requesting cardiac surgery without blood transfusion, patients declining transfusion. Now, Cooley saw this was a challenge, but he came up with a solution which involved excellence and innovation. And we all know this, as Dr. Usura mentioned earlier, that he's been recognized as the father of bloodless cardiac surgery. This is a time when large volumes of blood were transfused to perform open heart surgery, and it was considered impossible to perform cardiac surgery without transfusion. But Cooley felt these patients needed treating, and so he came up with a solution: bloodless surgery. In 1991, another innovator, Professor James Isbister, said that blood transfusion was previously seen as the gift of life, but the tables have been turned, and the general perception now is that bloodless surgery and the avoiding of transfusion may be the gift of life. Professor James Isbister in 2005 proposed the term patient blood management. And if you look at what he had in mind when he proposed this term, it's the same concepts that Cooley used in his development of bloodless cardiac surgery. James Isbister saw this as a patient-specific approach, and it was about managing the patient's own blood like any other organ or organ system, which is what Cooley did. He conserved the patient's own blood in order to improve patient outcomes. And so patient blood management is also now seen as a pragmatic solution to these problems with blood transfusion. And so, as already been mentioned, the World Health Organization came out with this policy brief earlier this year calling for the urgent implementation of patient blood management in all member states around the world. Also published this year, 26 experts representing 16 international societies published this global definition of patient blood management. And it acknowledges that this has its roots in the work done by Denton Cooley in the early 1960s, and what would become a paradigm shift in practice. Renowned cardiovascular surgeon Dr. Denton Cooley pioneered what would come to be known as bloodless surgery to accommodate Jehovah's Witness patients' request for treatment without allogeneic blood. In doing so, his team applied one of the fundamental elements of evidence-based medicine. Now, how would you define evidence-based medicine? I've made a practice of asking medical students how they would define evidence-based medicine. And it's surprising that many describe this as practice based on clinical trials, randomized controlled trials. Is that the definition of evidence-based medicine? Well, here is the definition: the integration of best research evidence with clinical expertise and patient values and preferences. So intrinsic to the definition of patient blood management is patient values and preferences. Cooley saw this. He saw patients with a preference and he accommodated their preferences in innovating and designing or developing bloodless surgery. This takes us back to Sir William Osler. He said, the good physician treats the disease, the great physician treats the patient who has the disease. He said it's much more important to know what sort of a patient has the disease than what sort of disease the patient has. So Cooley developed this three-step approach: optimizing patients preoperatively, using techniques to minimize blood loss, and he came to appreciate that patients can tolerate much, much lower hemoglobins than previously thought without resort to transfusion. And he regarded his bloodless surgery techniques as his greatest contribution to cardiac surgery. Now, this three-step approach that Cooley developed really developed into the three pillars of patient blood management, the same three-step approach to improve patient outcomes, and that's included in the WHO policy brief. If we come back to this global definition, you'll see again a similar theme here. Patient blood management is a patient-centered, systematic, evidence-based approach to improve patient outcomes as the goal by managing and preserving a patient's own blood while promoting patient safety and empowerment. Now, isn't this really the approach that Cooley took all those years ago? Patient-centered, managing and preserving the patient's own blood to improve outcomes. So Cooley in 1995 described his techniques, including the first pillar, to optimize the patient's blood prior to surgery. Listen to his comments about pillar 2.
Cut well, tie well, get well. In other words, you have to make incisions that are only necessary in length to accommodate the operation. You have to put a lot of attention to hemostasis. That's tie the bleeders off or else cauterize them. And then you can expect the patient to get well.
Cut well, tie well, get well, minimize blood loss. Another innovator and practitioner of excellence, protege, friend and colleague of Dr. Denton Cooley is Dr. Manuel Estioco, perhaps one of the most experienced bloodless cardiac surgeons in the world. And he followed in Cooley's footsteps. This is what he said: spending time in the operating room with Dr. Cooley had a lasting impact on my career. I was most impressed by his efficiency. Notice that word? Efficiency and effortless motions while operating in a relaxed atmosphere that only a master surgeon can muster. Well, Dr. Estioco went on to exemplify that in his practice of being in the operating room with Dr. Estioco on a number of occasions. This is a redo cabbage and valve replacement. And his signature was, he practiced and he taught what he called white towel surgery. And you can just see the dry field, which is a hallmark of his excellence in surgical technique. Another innovator, Dr. Richard Spence, the surgeon should enter the operating room with the goal of preventing as much blood loss as possible by maintaining careful surgical hemostasis. Back to William Halsted, one of the first proponents of meticulous surgical hemostasis. To emphasize the importance of this, William Halsted once said, the only weapon with which the unconscious patient can immediately retaliate upon the incompetent surgeon is hemorrhage. He really was highlighting the importance of surgeons being meticulous in their surgical technique to reduce blood loss. A famous British surgeon, Lord Moynihan, said the perfect surgeon must have the heart of a lion and the hands of a lady, not the claws of a lion and the heart of a sheep. Infinite gentleness, scrupulous care, light handling and purposeful, effective, quiet movements, which are no more than a caress, are all necessary if an operation is to be the work of an artist and not merely of a hewer of flesh. Blood loss is a problem. And so in the WHO policy brief, it highlights these adverse outcomes associated with anemia, blood loss, coagulopathic bleeding, and transfusion. Over 600 million individuals a year suffer from blood loss or bleeding disorders, major surgery, postpartum hemorrhage, heavy menstrual bleeding, GI bleeding, and blood being taken from patients in hospital, vampires, taking the patient's blood in large volumes and, of course, in trauma. What about the third pillar? Cooley had some very interesting observations about transfusion thresholds.
People have the idea that a surgical patient who has a blood hemoglobin level of 9 or 10 grams must immediately have a blood transfusion to bring his hemoglobin up to 12 grams. That's not necessary. I think 90% of our patients, even with their blood level down to 5 or 6 grams, do very well if you just modify their life and let their system take over the need for further erythrocytes.
Hemoglobins of 5 or 6 grams per deciliter, or 50 to 60 grams per deciliter. I don't know of any guidelines that recommend a transfusion threshold of less than 50 at this stage. And Cooley said this at a time where there was a transfusion threshold dogma that had developed. Transfusion was the default treatment for anemia, regardless of its cause, and it was based on a single arbitrary laboratory value, a hemoglobin concentration, which we know is not a good metric. Benefit was assumed. In 1942, this threshold of 100 grams per litre or 10 grams per deciliter was established. And if a patient needed a transfusion, he gave 2 or 3 units, not just a single unit. It wasn't until 1988 that this dogma of a hemoglobin threshold of 100 was challenged by the National Institute of Health Consensus Conference on Perioperative Red Cell Transfusion. And they actually recommended, based on physiology, a threshold of less than 70 grams per litre. Our group conducted this systematic review and meta-analysis of systematic reviews and meta-analyses of liberal versus restrictive transfusion threshold. This is called an overview of systematic reviews. It included 53 unique randomized controlled trials. It reported on 19 systematic reviews pooled by 33 meta-analyses. The primary outcome was mortality in restrictive versus liberal transfusion thresholds. In the meta-analyses graded as high to moderate level of grade, in 75% of those meta-analyses, there was no benefit identified for liberal transfusion thresholds. In 25% of those meta-analyses, it favored restrictive thresholds, reduced mortality with restrictive thresholds. We conducted this large study in Western Australia to determine if there is a hemoglobin concentration where transfusion becomes effective using an interactive model. This was the second in the top 10 articles in the journal Anesthesia that year. So we used this interactive model of anemia and transfusion in surgical patients, and we looked at these various hemoglobin thresholds, comparing transfused patients with adjusted patients that did not receive transfusion at those hemoglobin levels. Over 60,000 patients from 3 major tertiary hospitals. These are the surgical populations we included, and the outcomes were mortality in hospital, 30-day and 1 year, and hospital length of stay. Now, if you look at this graph here, we could not find a hemoglobin value where transfusion was beneficial in reducing mortality. Up this end of the scale, at 90 and above, transfusion was associated with harm compared with patients not transfused. These are risk adjusted. Below that, we could not find a benefit even down to thresholds less than 60 that Cooley talked about. Now down here, the numbers got smaller, and so the confidence intervals are wider. But nevertheless, there was no benefit seen with transfusion compared with not transfusing patients with regard to in-hospital mortality. The same picture for 30-day mortality and the same picture for 1-year follow-up mortality. Harm this end, no benefit down this end. Length of stay was a different picture. We saw increased length of stay in patients transfused at every hemoglobin level down to a hemoglobin of 60 to 90. Below that, less than 60, no difference that we could see, no benefit. Coming back to this systematic review of meta-analyses of randomized controlled trials, what became apparent in this review is the wide variation in what is defined as liberal versus restrictive. And within the meta-analyses, there was wide overlap in those thresholds. And in some trials within the same meta-analyses, the restrictive threshold was higher than the liberal threshold in other trials. So these trials have limitations, and we need to be careful about their interpretation. There was one meta-analysis that was different, one by Salvage, where they got a good separation between the thresholds. They only selected trials with a more restrictive threshold, less than 70 compared with liberal. They did a secondary systematic review of observational studies to evaluate even more restrictive thresholds, 30 to 60 grams per litre or 3 to 6 grams per deciliter. What they found with these more restrictive thresholds was decreased mortality, both in hospital, 30-day and total, reduced acute coronary syndrome, pulmonary edema, rebleeding, and bacterial infection was less in the restrictive threshold group. In their secondary analysis of observational studies, they concluded in surgical patients, the critically ill and patients with acute bleeds, hemoglobin levels of 50 to 60 are well tolerated when combined with supportive care. That's the thresholds that Cooley talked about, right? 50 to 60. They found no evidence of cardiac ischemia or inadequate oxygenation until hemoglobin levels decreased below 30 to 40 grams per litre. There's also numerous case reports in patients declining transfusion where clinicians have managed extremely low hemoglobins without resort to transfusion. Dr. Asuru published this one in severe obstetric hemorrhage and severe post-obstetric hemorrhage anemia. A hemoglobin of 1.3 grams per deciliter or 13 grams per litre managed successfully without transfusion. Other clinicians are starting to realise that the hemoglobin concentration is not a good metric to guide specific therapy. For example, Dr. Eva Beverina has published on this. Now, this is in a patient where transfusion was an option and was acceptable to the parents. 13-year-old presented with a hemoglobin of 3.3 grams per deciliter. She had severe iron deficiency due to heavy menstrual bleeding. And the doctors decided not to transfuse this young girl, but to manage her differently with a good outcome. Then a 79-year-old female presented to the hospital with a hemoglobin of 3.8 grams per deciliter with cytopenic anemia. Now, she was asymptomatic with this very, very low hemoglobin. She'd been on PPIs for a while, a long history of rectal blood loss due to hemorrhoids. They decided to manage her without transfusion, again, with a good outcome and rapid response to hematinic therapy. This very, very interesting systematic review and meta-analysis was just recently published in Transfusion by Dr. Petra Seaver and colleagues. Some of my colleagues were involved with this, where they were looking at mortality and morbidity in non-transfusible patients and transfusible patients. So this wasn't looking at transfusion versus no transfusion. This was looking at patients in whom blood was not an option and patients, matched patients, where transfusion was an option. Here's the meta-analysis looking at mortality. As you can see, there was no increased mortality in the non-transfusible patients. The odds ratio is 0.87. Now, it wasn't significant, and yet you look through these and the point estimates are rather interesting, but this is reassuring, no increased mortality. In the secondary analysis, meta-analysis of secondary outcomes, You can see, looking down this right-hand side here, there was no increased morbidity involved with patients that were not transfusible, or where transfusion wasn't an option, compared with those where transfusion was an option. Interestingly, if you look at infection, acute myocardial infarction, reoperation, there was a trend towards reduced infection, MI, and reoperation. Not significant, but a trend towards that. This was, however, significantly different. The length of stay in intensive care in the non-transfusible was significantly reduced. They also did a subgroup analysis of patients with severe anemia and hemorrhagic shock. And again, there was no significantly increased mortality. So the authors concluded the results may reassure clinicians that observational studies of low to moderate risk of bias indicated patients unable to receive allogeneic blood transfusions have similar clinical outcomes, and in some instances may have better outcomes than patients able to receive transfusions. Patients considered non-transfusible were treated at similar or reduced hospital costs, which is also interesting. Such was the interest in this meta-analysis that the authors were invited to present these outcomes to the US Food and Drug Administration, or FDA, journal club just recently. So what about outcomes? Let's listen to Cooley's observations with his approach.
One critical group of patients were people who refused to accept blood transfusion. This was a religious group known as the Jehovah's Witnesses. And I could compare those patients who had no blood products whatsoever with another group of patients who underwent conventional sort of blood replacement. And the results seemed to be better in terms of morbidity and mortality among those patients who had refused blood transfusion.
So his impression was patients did better with this approach. So coming back to what we're celebrating, excellence and innovation, particularly looking at this aspect of innovation, transforming these ideas into reality, and creation, development, and implementation of a new product, new process, or new service with the aim of improving efficiency and effectiveness. The World Health Organization policy brief reproduced the infographic of the results of the West Australian patient blood management program that I was involved in designing and implementing. This was the world's first health system-wide, public health system-wide patient blood management program. It started off in the state with the lowest red cell transfusion rate in high-income countries. So there's already a very conservative approach to transfusion where we started this program. When I approached the director of the Red Cross to explain what we're doing, he said, "Why on earth are you starting here? We already have the lowest transfusion rate in the world." And we said, "We think we can do better." And this program was basically built on the same three-approach strategy that Cooley developed over 60 years ago. Talking about excellence, innovation, efficiency, effectiveness, this program saw increased effectiveness and efficiency. So despite having a very low transfusion rate to start off with, we saw a 41% reduction in blood transfusion, 41% for red cells, 47% reduction in plasma, and a 27% reduction in platelets. And this is across the whole hospital population: trauma, obstetrics, burns, surgical, medical, hematological patients, transplantation patients, across the whole range of patients. Reduced transfusion with improved outcomes. 28% reduction in mortality, infection reduced by 21%, AMI stroke by 31%, and length of stay 15% reduction, with significant cost savings, up to 80 to 100 in estimated activity-based costs or blood product activity-based costs. So increased effectiveness with increased efficiency, all based on what Cooley pioneered all those years ago. This book has just been announced. 48 international authors contributed to this publication. There's a chapter on pediatrics and neonatology, and there's a chapter on women's health, the topic of this Bloodless Surgery Week. The authors in this chapter said PBM is well established in adults and is recommended by international experts as a new standard of care. Unfortunately, its acceptance as a standard lags in the care of babies and children. The implementation of PBM in neonates, infants, and pediatric patients is seen as an urgent, unmet medical need. The chapter on women's health, the authors state, this approach can improve outcomes for women, mothers, and babies. PBM is well established in other areas of medicine and surgery. However, there is still little awareness among primary care physicians, emergency department physicians, hospital doctors, obstetricians, obstetric departments, and gynecologists of the importance of PBM in improving women's health. Here's the problem. It's estimated that 1 billion women around the globe suffer from anemia. An additional 1.2 billion, it's estimated, suffer from iron deficiency without anemia. Both of these are associated with adverse outcomes. So 2.2 billion women possibly suffering from iron deficiency and anemia. And anemia has been identified as the leading cause of years lived with disability in females. Maternal health and child health is a real need. There's a real need in this area. And that's why this week is devoted to improving outcomes in maternal and child health, employing the principles of bloodless medicine. Coming back to the WHO policy brief, there is this call to action. All member states should act quickly through their ministry or Department of Health to adopt their national PBM policy, install the necessary governance and reallocate resources to improve the population health status and individual patient outcomes while reducing overall healthcare expenditures. This article in the New England Journal of Medicine, A Glimpse of the Next 100 Years in Medicine, said the era of shifting more and more economic resources toward healthcare is going to end. The medicine of the future will focus on more efficient use of resources. Is Bloodless Surgery Day worth celebrating? Certainly is, because it celebrates excellence and it celebrates innovation. With the aim of that is to improve efficiency and effectiveness, improve patient outcomes while reducing costs. Thank you very much for your kind attention.
Thank you very much, Shannon. We really enjoyed that and found that very informative. Carolyn is having some Wi-Fi difficulties, so I'm jumping in as needed. But I'm looking at all of the comments. We're up to almost 370 participants worldwide, and there were very many appreciative comments expressed. I believe we're going to have a Q&A on this segment. So let's see. I'm bringing up my box for that. Let's see. So first of all, were there questions that we can address? I'm looking now. I haven't seen any, but we'll stand by. And you are available to answer questions as needed for time, are you, Shannon?
Yes, certainly, Kevin, can do that.
Okay. So it may be simpler to put them in the chat box. Or if there's another way, Nat, did you want to handle that? How we would handle that? Otherwise, we'll stand by. But I'll address some of the questions. You might see them, but some of the questions initially, one of the questions coming in regards Hemopure, what role that plays in therapy. Did you have a comment on that, Shannon?
Well, of course, there's been a lot of work done on the hemoglobin oxygen carriers. And I think what they have manifest, what they have revealed is that red blood cells, and particularly the hemoglobin, are much more complex than ever was realized. And so some of the early work saw some adverse effects of those. but there's still a lot of work being done on them. There are some questions about how the trials were run and the outcomes of those trials. But clearly, there's still a lot of work being done as an option for where transfusion may be indicated. But they're still a little way off at this stage. But we're available. It's been used in patients with obstetric hemorrhage and trauma. We have used it twice here in Western Australia. We had a young man, 25 years of age from memory, who had a very bad motorcycle accident. He presented to our ED at one of our hospitals with profound anemia. He just had a personal preference not to have blood. He just said, look, I don't want a blood transfusion. It wasn't for religious reasons. He just perfectly didn't want it. So that was accommodated, and the clinicians did notice some ischemia developing, cardiac ischemia, and so we got a hold of some Hemopure, and that was administered, which saw an immediate resolve in the symptoms. But we also gave him our hemoglobin maximization protocol of IBI, erythropoietin, B12 folate, and ascorbic acid, which is a cocktail we've developed based on witness patients with profound anemia to get their hemoglobins up very, very quickly. We've seen remarkable responses to that. So in this case, we gave that at the same time. And often when you administer these HBOCs, the hemoglobin drops off again very quickly. But in his case, that didn't happen. His hemoglobin just continued to rise. And so he was managed successfully. I think his hemoglobin dropped below 2 grams per deciliter at one stage. So clearly there's a role for it in certain situations, but there's so much more we can do now to make sure we don't get to that level and manage patients even without that being available. But if it is available, it can play a role for sure.
Thank you. Very, very helpful. And again, your presentation, outstanding. There are comments still being received. I think we're requesting for everyone to use the Q&A feature for submitting questions. So I'll pick through some as best we can. One has to do with digital health. And the question had to do with how may we bring awareness to bloodless surgery into the new generation of digital health. What observations do you have on that, Shannon?
Well, I think universities around the world are really seeing the importance of social media getting the message out. Our university actually runs courses on how researchers can use social media to get the results of their research out. And that's the modern generation, of course, they rely upon that. And of course, the public uses that, and we need to engage patients. We need to engage the public. So it can be used very well. And as I say, more and more universities are using it, many routers that are using it. I think there's a need for more PBM people to be on there. At this stage, their presence isn't very high, and there's a real need for them to be on there to get this message out.
Good. We'll take that as some good encouragement. And here's an interesting question as well. It says from one, just out of curiosity, the question says, what was the purpose of the white towel surgery?
Sorry, I didn't explain that very well, but essentially the white towel show up blood loss very well. So the idea is to have those towels white at the start and white at the end of the procedure. So it's just a good reminder to be very careful that every drop of the patient's blood is precious, and do everything possible to keep it where it belongs in the patient.
We have to appreciate Manny's approach to that, don't we? And appreciate you sharing that as well.
And he was a master at that, wasn't he?
Yes, he was. You've piqued our curiosity too regarding the new book, Bloodworks, an Owner's Guide. So of course we're getting questions on that, how that can be accessed.
Well, it's a pre-release. It's on Amazon.com. So if you search Bloodworks and Owner's Guide, you'll find it on Amazon. It'll be released in electronic as an ebook and as a print copy in October, but you can go on and pre-order now if you're interested in having a look. It covers the whole spectrum of patient blood management. It covers trauma, it covers obstetrics, women's health, it covers hematological disease. There's a section on blood physiology, pediatrics, neonatology, and in resource poor countries, PBM in resource poor countries. So we've tried to cover every topic in the book, and I'm very grateful to 48 international experts who made enormous contributions to what will be a very valuable book, we're sure, to patients, but it's designed to be useful to clinicians as well.
And needless to say, we're excited. We really can't wait to get our hands on it. I think what we're going to try to do as well is give a preview in the next SABM newsletter. So we've reached out for book reviewers. So keep that in mind for the next SABM newsletter, which will be out prior to September. We certainly want to feature excerpts from Shannon Farmer's book, because that's going to be very helpful. You mentioned resource poor countries as well. So very, very helpful in that regard that we'll want to benefit from. So we look forward to that.
Yeah.
Thank you, Kevin. Thank you for that.
Yeah, Kevin, thanks for
Yes.
fielding, taking care of some of those questions. I apologize to people. I keep getting kicked off and it's on my end. Just in general, Shannon, this is outstanding information, and just this whole concept of the patient-centered approach and blood as the organ. I think blood health, all of these concepts, sadly enough, I think are very new to a lot of clinicians. So this is really the message that we want to be putting out across the globe. I think everyone that's in this room, which we now have 371 people, would absolutely agree. Now, I do see one question as well here that is coming. Do you necessarily need to be placed on a specific diet after a bloodless surgery? That kind of brings up this whole concept of post-operative care. So maybe a quick comment about that.
Look, that's a really, really good question, and it's raising a really important topic. We haven't done very well in the past in closing the loop of the continuum of care. So patients get discharged from hospital, and there's a couple of big studies. Matt Warner did one that shows of those patients who were discharged anemic, about 50% are still anemic 12 months down the track. So they're being sent home, discharged anemic, and many of them stay that way, and many of them become iron deficient, replacing or reconstituting the hemoglobin they've lost during surgery or obstetric hemorrhage. So there's been this focus on restrictive versus liberal and tolerating anemia, which is a useful strategy, but then we tolerate anemia to the point where we send them home anemic and they suffer down the track from the adverse effects of anemia, which is fine short term, but long term, not such a great idea. So closing that loop is really important. And diet plays an important role. Good nutritious diet is always good pre and post-operatively. But we need to do more before they're discharged to make sure that we're seeing them home in the best condition, but then also to communicate to primary care physicians. Now, we here in Western Australia, about 50% of our GP clinics have iron infusion clinics now in Western Australia, and the GPs have been educated that they can play a role early. They see the patients first, the primary care physician, and then they end up with them once they're discharged from hospital. So we need to do a lot of work in engaging primary care physicians to make sure that that follow-up is performed, and good communication between the hospital and those who will be the family care physicians who will be looking after them later. Yeah. So good question.
Good, great. I think it's very important. And we do probably need to be moving on. And just another little housekeeping item. Dr. Farmer will be able, if you want to continue to type some of your questions into the Q&A box, then he will be able to answer some of those as we roll through. But I think we need to get started with our second speaker, if we could. And Kevin, I'm going to let you do the honors.
Thank you, Carolyn. We're glad the Wi-Fi was able to be reconnected for you. That's the one thing we can't count on, the electronics.
Exactly.
So.
Yeah. Thanks.
And again, Shannon, thoroughly enjoyed that. Looking forward to more. Now moving along, we're pleased to welcome Dr. Michael Jones. I had the privilege of hearing him a while back, obstetrics and gynecology, outstanding accomplishments in that regard. But just to give us a bit of a background, obstetrician and gynecologist, he provides a full spectrum of obstetric and gynecological care. Special interests include laparoscopic surgery, high-risk obstetrics, and of course, blood conservation. a bit of a background on Dr. Jones that we'll find of interest, as well as work experience. He's a member of the Board of Trustees, Cape Fear Valley Medical Center, so he's right here in the Louisiana area. Course director, obstetrics and gynecology, Methodist University PA program. He's also chairman, Department of Obstetrics and Gynecology, Cape Fear Valley Medical Center. He's the owner, staff physician of the Jones Center for Women's Health, medical practice, obstetrics and gynecology. And in this regard, he practices or provides a full spectrum of obstetrics and gynecology. He's performed over, note this, 9,000 deliveries and 4,500 gynae surgeries of all types. Extensive experience and, of course, education. So I think we'll find his presentation very interesting. It's very helpful. I'll give a shout out, if you don't mind, nearly 370 participants, many members of hospital liaison committees, of course, hospital information services, hospital information desks, and HLCs worldwide. So this is of particular interest on women's health. So let's give our attention now to Dr. Michael Jones. We welcome you warmly.
I don't believe he's connected at the moment. I'm so sorry, Kevin, right?
Okay, I was looking myself. I did not see him as of yet.
Is it possible to move on to the next lecturer?
Yes, we can. I see John. How are you feeling? We welcome you, Dr. Waters. We know you've had a tough month, but it's...
Thanks, Kevin. It has been a tough 6 weeks.
Yes, it's good to see you.
Thank you.
Good form, and we welcome you. You've been through a lot, so we're most encouraged that you're feeling better, of course. Carolyn, did you want to take the introduction?
Sure,
Okay.
absolutely. Yeah, John, just consider, just a warm welcome, and we're so glad you're back with amongst us in the fold. Tough times, and we've been thinking of you during it. So for those of you, I imagine most everyone in the room is familiar with Dr. Waters. He is, again, one of our other pioneers and giants in the world of bloodless, as well as comprehensive patient blood management. John's official title is he's the professor of the Department of Anesthesiology, University of Pittsburgh, chief of the Division of Anesthesiology, McGee Women's Hospital, University of Pittsburgh Medical Center. So he is also a past president of SABM, I must say, a longtime colleague. He's been an innovator in the world, particularly in the obstetric and gynecologic arena, has many publications, as we're all very much aware, and much of this is surrounding cell salvage. And I've just recently finished reading, John, your most recent article that you had in Transfusion, where you were talking about the use of cell salvage in vaginal delivery. So fascinating way to look at ways to expand our range and use that evidence to push the blood management arena going forward. So without further ado, I'm going to let John take it, and he's going to be talking about anesthesia and perioperative care in bloodless obstetric surgery. So John, thanks again, and you have the floor.
Thank you, Carolyn. Can you see my slides?
Yes, we can. All good.
Okay. So I will start. Nat asked me to speak on anesthesia in bloodless obstetric surgery. So that's going to be my focus, is the anesthesia care in a bloodless obstetric patient. So I'm going to hopefully use a number of case examples to illustrate how I go about approaching these particular patients. But before I start, this is where I'm speaking from. It's in Pennsylvania, in the city of Pittsburgh. And this is the city of Pittsburgh at the point, which is where the two rivers, the Allegheny River and the Monongahela, come together. And I've put a star where the Jehovah's Witness Church was founded. It's on the north side in what used to be called Allegheny City. It's near Heinz Field, which is our football stadium. And there's a plaque at the location where Charles Taze Russell founded the Jehovah's Witness Church So we have a fairly high concentration of Jehovah's Witnesses in this region. And they've been mismanaged for probably the last 20 years until we formed our Bloodless Medicine program. At this point, we see about 1,600 Jehovah's Witnesses come through our doors, with about 25 of them achieving what I call severe anemias, meaning less than 5 grams per deciliter of hemoglobin. Just to get started, there is a great website, jw.org, that has some information for clinicians. It's a fairly extensive amount of information. So if you're looking for hints on how to care for these patients, this is the place to start. Now, one of the pages in this website is shown here, where it highlights what most Jehovah's Witnesses, or at least all Jehovah's Witnesses, will refuse, which is the main components of blood: red cells, white cells, platelets, and plasma. But there is also potentially acceptable products, and these are things that need to be discussed with every patient individually. And these are particularly important products, especially fibrinogen, which can be attained either through fibrinogen concentrate or through cryoprecipitate. And then there's also blood salvage, as Carolyn alluded to. Auto transfusion or blood salvage is kind of my baby. I think it's one of the most adaptable strategies for taking care of these patients. To illustrate this, this is a Jehovah's Witness that we cared for about a year ago. She presented at 35 weeks gestation with an IUFD, or intrauterine fetal demise, from a placental abruption. And as an OB anesthesiologist, this is one of the most feared presentations because of the coagulopathy that develops with one of these abruptions. This particular patient, her INR natored at 15.3, which is pretty much unheard of. Her platelet count natored at 100,000. Her hemoglobin natored around 3. She was a patient that we ended up giving Hemopure to because of that low hemoglobin. A D&E was performed, and bleeding was treated with multiple factors: 4-factor PCCs, tranexamic acid, vitamin K, and 85 units of fibrinogen concentrate. And subsequently, her INR normalized to 1.3, and she was subsequently discharged home on post-op day number 5. So this kind of illustrates the importance of fibrinogen to the care of these patients. And I think what you can do is you can surpass low platelet counts by kind of hyper concentrating the fibrinogen concentration. So if a patient is agreeable to fibrinogen concentrates, it's something that should definitely be considered. Now, there's a website that was developed by the California Maternal Quality Care Collaborative, as is shown here. And there is a series of steps that they recommend that you take when managing one of these obstetrical hemorrhage patients. And the first thing, and this is the resource link where you can find it, but the first thing that they recommend is that you stratify patients for risk of bleeding. And this is what they recommend you do. Now, for a Jehovah's Witness patient, it's a waste of time to type and screen and type and cross-match a patient. But I think it's important to identify patients who are at high risk of bleeding during the course of their care. And we've done some mathematical modeling on our database, which contains about 80,000 patients in it. And these are in bold the areas where we found there was the most risk for hemorrhage during the course of delivery. And unfortunately, singleton pregnancy was the greatest risk of bleeding. And I think these are because they labor for 2 days, develop chorioamnionitis, become refractory to Pitocin. So it's really kind of a crapshoot as to who is going to bleed. Some of the other things that they recommend is that you should transfuse 2 units per clinical signs. Now, I got a real problem with this, regardless of whether or not it's a Jehovah's Witness. I think that the patient should be transfused based on clinical presentation and laboratory values. Other things that they recommend is establishing IV access. And this is something that we have run across in patients that have been life flighted into our hospital, is they oftentimes come with a 22 gauge IV hanging out of their arm with very little opportunity to get additional IV access because they're so hypovolemic. So we've started using intraosseous drills to a larger degree because you can put one of these lines into a patient in about 3 seconds, and it runs like a 16 gauge IV. So you can resuscitate somebody very, very rapidly with an intraosseous line. Stage 3 in the CMQCC recommendations is making sure that you aggressively treat the patient with uterotonics. One of the things that I have problems with is the use of Hemabate. It's oftentimes avoided in patients that have histories of asthma or bronchospasm. And I think you need to really balance, the benefit of Hemabate in this particular environment. I mean, we have lots of treatments for bronchospasm, and it's growing by the day in terms of the numbers of drugs that we can use. Whereas hemorrhage has an ultimate end, which is not good. So if you need to use this particular drug, I say go for it. Blood products, there is a recommendation within the CMQCC to use the 1:1:1 ratio. I'm a massive opponent of this particular strategy. I think it should all be laboratory guided. And there's some work that Jeannie Callum published out of Canada where she showed that laboratory-based transfusion led to significantly better outcomes than the 1:1:1 transfusion strategy. Now, granted, this is not something that you would be exposing a Jehovah's Witness to, but it is something to keep in mind for other patients. So the next patient I'm going to present is a Jehovah's Witness who presented for an elective cesarean section to our hospital. She had a previous delivery where she had a significant bleed, and she presented to our operating room with a hemoglobin of 9.6, which is problematic. The World Health Organization defines anemia for a pregnant patient as anything less than 11. So this patient was clearly anemic. She had autotransfusion or cell salvage implemented during the course of her surgery, but her uterus became atonic. She ended up with a hysterectomy and then was transported to the ICU where she became unstable, at which point we opened her at the ICU bedside where a pedicle bleed was noted and tied off. And her nadir hemoglobin was 1.7. And this really illustrates how tolerant the pregnant woman is of severe anemias. And I don't think we have good data as to what the endpoint is. But this particular individual did extremely well. On post-op day 1, she looked so good that she was extubated. And when I went to see her in the late afternoon after her surgery, she was playing with her kids in the hospital bed, saying that she was a little tired. And at this point, her hemoglobin was 2.7. So I think the obstetrical patient is fairly tolerant. And if you think about it, nature probably has designed the pregnant woman to be tolerant of severe anemias because it's something that they would face without modern healthcare. So antepartum anemia management is something that I think should be a focus of any obstetrical unit. what this means is we treat iron deficiency. And this is a slide of some data that was collected that shows, the iron stores, during the course of gestation. And you can see they shrink to about 20% normal during the course of the 3 trimesters. So I think we underutilize iron supplementation. And in fact, it's more the patient preferences. They don't like to take iron. Erythropoietin is probably a waste of time in most obstetrical patients because erythropoietin concentrations go up, as is illustrated by this work. But I think the vast majority of anemia in pregnancy relates to iron. And this is something that's very cheaply treated. This is a bottle of iron from a local pharmacy. And the cost of iron is about 2 cents per 65 milligrams. So as a first line therapy for iron deficiency, this should be it. Now, Manuel Munoz in Spain has published this work where he looked at the cost of intravenous iron. And I think we way underutilize intravenous iron. And there is a general fear of cost and a general fear of anaphylaxis. And I think both are unreasonable fears. As you can see, the costs of the particular iron molecules is cheap. And there's almost no anaphylaxis that occurs with the modern molecules. If you compare this to red cells, $225 for the average unit of red cells in the United States versus $10 for a dose of IV iron. It's a no-brainer in terms of the economics. So one of the things that was seen with the patient that I mentioned just a moment ago was the patient went from a hemoglobin of 1.7 to 2.7 within 24 hours. And you can see from this graph of patient blood volume, what happens immediately after delivery is there's a rapid concentration that takes place. And this basically corrects many anemias that develop during the course of delivery, or rather gestation, is that there is about a 3-day period of time where there's a hemoconcentration that can correct many anemias, at least relative to our laboratory values. So one of the things that we've done in our hospital is we've developed a checklist for both the obstetricians and for the anesthesiologists. This is a checklist that we use for our anesthesia providers. And one of the things that we have identified as being important is aortic cross-clamping, which is something that's kind of been lost in the obstetrical world. But there's a newer device called the REBOA, or the retrograde endovascular balloon occlusion of the aorta. And this is a device that can be floated up through the iliac artery up above the uterine arteries to stop blood flow while control is obtained of that blood loss. Other things, monitoring of hemoglobins and thromboelastographs during the course of care will optimize the management of the patient's hemoglobin and their coagulation function. And some of the devices that we use, this is a thromboelastograph, the newest generation. It's called the TEG 6S. And it gives you 4 different tracings, one of which is a fibrinogen concentration. If you look at the lower corner, which is highlighted in yellow, that's the fibrinogen concentration for this particular patient that was bleeding. You can see it's super normal, which is typical of pregnancy. At 633, a normal patient would have a fibrinogen level of 200. So we want to keep this fibrinogen level up, which highlights the importance of fibrinogen transfusion or fibrinogen concentrates. Other things, HemoQ use, hemoglobin measurement during the course of care. can be important, perhaps not in the Jehovah's Witness patient, but in the regular patient. And HemaQ takes 20 microliters of blood to fill up this cuvette on the right side in order to get a hemoglobin concentration. And I think this can guide red cell transfusion. So moving on, this is a patient that I took care of when I was at the Cleveland Clinic, which was 18 years ago. This was a non-Jehovah's Witness patient who presented with vaginal bleeding to our labor suite. I believe she was 30 some odd weeks pregnant, but anyway, she presented with a hemoglobin concentration of 6.8, a blood pressure of 57/17, and a fetal bradycardia. So general anesthesia was induced and maintained with propofol, and the importance of this is that general anesthesia should avoid our inhalational agents because they all relax the uterus, which leads to increased bleeding. So we now basically manage all of our general anesthetics with propofol administration. And this just highlights this particular thought or concept. So in managing this particular non-Jehovah's Witness, we called the blood bank asking them to send us some red cells. But upon delivery of the placenta, it was discovered that she had a placenta accreta. Initially, it was thought she had a vasa previa. And this particular placenta accreta happened to be right under her symphysis pubis, so it was very hard to reach. One of the other things about this particular patient is that she had been transfused previously during the course of an auto accident. So she had multiple antibodies, and the blood bank basically said, we got nothing that is compatible for this particular patient. So we implemented autotransfusion, and that this was at a time where autotransfusion was considered contraindicated in the obstetrical patient. A hysterectomy was performed, and we were able to scavenge 3 units of cell salvage blood, and she left the operating room with a hemoglobin of 5.1. And this is how she did clinically post-delivery, is that she hemoconcentrated, as I mentioned, and she was discharged on post-op day 4, which is typically 1 to 2 days longer than a normal post-cesarean section. But she received no blood products during the course of her care, despite her nadir hemoglobin. So this kind of highlights why I'm a big fan of autotransfusion, is that it gives you flexibility to take care of patients that present with unrecognized or unpredicted blood loss, is that you can implement this particular strategy very rapidly, and you can provide large quantities of blood. And my own personal record is 279 units of blood for a particular patient, not an OB patient, but a patient that suffered from an aortic aneurysm rupture. But the use of autotransfusion in postpartum hemorrhage was first discussed by William Highmore in 1874, where he observed a woman bleed to death following a delivery. And he thought, gosh, all that blood that's in her bed, perhaps it could be collected and used for resuscitation. So this was the main way that patients were resuscitated for about 70 years. And this is a case report from 1934, reporting on ectopic pregnancies and the use of, this is non-washed autotransfusion or cell salvage blood. There is a company called Sisu Global that has been marketing a device that looks like a giant syringe, is being shown here, where you suck blood out of the patient, you pump it into a blood bank, as is shown on the left side of the slide in the lower corner. And then this unit of blood is basically hung and reinfused. And again, this is unwashed blood. So, for a resource limited environment, I think we can go back to the era of unwashed blood and dumb it down a little bit, because patients tend to fairly well tolerate this unwashed blood. And this was recognized back in 1974, where this Bentley autotransfusion device was developed. And the whole goal of this was to collect unwashed blood in this reservoir that looks like a sphere on the top of the machine, and to basically pump it back into the patient. The only problem was that there was no fail-safe mechanism when the sphere ran out of blood, so it would pump air into the patient. So this device led to air emboli, and so was quickly taken off the market. Now we have these washing devices, and this is the list of devices that are available. And there's some misinformation that's available or circulated about the need for a continuous circuit when caring for a patient with autotransfusion. And this is a case report that highlights this misinformation about how this particular patient was agreeing to bypass, but was against a discontinuous circuit with a cell salvage device. And these particular devices all do batch processing, meaning they process batches of blood, whereas the CATS device does continuous processing. So I think it's been a marketing ploy for the CATS to advocate for this continuous circuit, because they're the only device on the market. And this is how you do it, and I'm going to just skip through this. This will be available online. But this is something that's I've investigated with the Watchtower as to the need for this continuous circuit. And what they tell me is that there is no doctrine that requires a continuous circuit, in that this is basically something that's left to the conscience of the individual as to whether or not they believe this circuit is an extension of themselves. And generally, when a patient requires this, it's significantly more difficult to provide this care. And we usually bring in our lay liaisons to talk to patients about this when they require it or demand it. So this is some of the contraindications historically associated with autotransfusion, one of them being use in obstetric surgery. And I'm going to quickly flip through this just because I think we're time limited. But this is a collection of case studies that was composed by Giancarlo Liambruno in Italy, where he identified 1,665 cases of autotransfusion being performed in obstetrics with no adverse outcomes. So moving on, I don't think we'll ever prove safety, but I think we can rely on those 1,665 cases as being good evidence that it's safe. But in order to prove safety, you would need to power a study with 1.7 million subjects in order to have an error rate that was low enough that you could prove that it was appropriate. But what we need to do really is look at surrogate measures of safety. And these are some of the surrogate measures that I've looked at is biochemical washout, cellular contaminant washout, and bacterial contaminant washout. And again, I'm going to skip through this just because of time limitations. This particular filter will remove all particulates. And this is some slides of what we've demonstrated. And this is a slide of 33 patients that we looked at a number of different contaminants in cell salvage blood. And we found that following a wash and following the filtration, we could provide a product that was equivalent to what's actually circulating in the mom. bacterial contaminants is an interesting area that I think is worth addressing. We contaminated a number of different units of blood with the bacteria shown on the far left, E. coli, Staph aureus, Pseudomonas, and Bacteroides, and found that we could remove with the washing and the filtration process almost 100% of these particular bacteria with this processing, which forces you to think about the alternative, which is blood from the blood bank. And this is work published by Rosalind Yamtovian in Cleveland, where she found that platelets that were transfused were also contaminated with bacteria. So these small degrees of bacterial contamination probably have no clinical significance. So as Carolyn alluded to, we have started doing cell salvage in vaginal deliveries, and we've been using this device, the HemaSaver, which we have parked in all of our labor suites or our labor rooms, where we can implement the collection of lost blood at a moment's notice. And the blood from this particular collection reservoir can easily be moved into an autotransfusion device for washing and filtration. So because of the safety that's been shown, there are now a number of organizations that recommend the use of autotransfusion in obstetrics, and these are some of the organizations, most prominently in the UK, as well as the California Maternal Quality Care Collaborative, which is pretty much the biggest organization in the United States that recommends safety measures in obstetrics for our patients. So just a couple of things to make salvage effective in this environment. Most importantly is regulation of suction. It should be down-regulated as much as possible because suction pressure will damage the red cells. And then rinsing of lap sponges is critical. This is a lap sponge that's fully soaked with blood. With rinsing, we can remove about 95% of those red cells and then suck it into our collection reservoir and process it. And we've done some work where we've demonstrated that we can remove 95% of the red cells from a lap sponge, which is significant. There are some other things I just wanted to touch upon. Iron deficiency anemia. These are all things that should be focused on in the postpartum period. The reason is that the consequences of iron deficiency in the postpartum period are significant, is illustrated by this table, where we see work efficiency, fatigue being reduced for that particular individual. And when you're trying to take care of a newborn, having your work efficiency being impaired is particularly impactful. So just to skip on because of time, I will flip over into the question session. I think I've left 14 minutes for the next speaker, and I apologize for running over what was scheduled to be my time.
Yeah, no worries, John. Yeah, we got a bit behind, and part of that was my issue with coming and going with my Wi-Fi, so that's on me. But thanks, John. This was really informative. And before we do any Q&A, actually, I believe Nat has made me aware that Steve Frank has joined, and Steve wanted to make some special comments, and he may have some questions for you too as well. Steve, are you on?
Yes, indeed. Hi, Carolyn.
Hi.
Great to be with you. Shannon, great talk. John, really, really nice talk. I just want to emphasize that what Shannon said about keeping the blood in the patient is so important, because all the iron and erythropoietin in the world can't make up for significant blood loss, because, you know, we have about 5 liters of blood in our body, and there's nothing more important than keeping the blood in the patient. I also want to say to Shannon, your meta-analysis of meta-analyses is probably the highest level of evidence that we can get. And when you said that liberal transfusion doesn't add benefit over restrictive transfusion, that's convincing evidence, no doubt. And John, I want to thank you because all the work you've done with cell salvage, especially in the obstetric world, really has saved lives. At first, people said, oh, you can't use cell salvage because the amniotic fluid is a contaminant, but you've written about and told us how to use it safely. And you've even published a case series of successful use of cell salvage in pregnancy. And last thing I want to say is with the severe shortage of blood that we've seen across the world ever since the pandemic began, patient blood management is now more important than ever, and bloodless medicine is more important than ever because we've never seen shortages like we have in the last 2 years. So thank you all for amazing talks this morning.
Thank you, Steve. Thank you very much.
Thank you. I think what we might do because of our time, John, if you are able to stay on, and we'll go ahead. I'm going to let Kevin introduce Dr. Jones. I believe, Kevin, he's online.
Yes, yes.
Great. Why don't you go ahead and then we will get started there. And if people want to remain online for a kind of a group Q&A, then we'll be able to do that. So thanks. I'll turn it over to you.
Thank you, Carolyn. And John, you look great. You've been through a lot. And for those that don't know, you were hospitalized there for a while and you're on and you picked up as though nothing happened at all. So thank you. I reiterate Steve Frank's comments as well. So thank you. And we're just glad you're doing better and recovering. As mentioned, we're happy to have Dr. Michael Jones now from the US. There were some connection difficulties. That's the one thing we can count on. Our connection challenges, Wi-Fi, computers, passwords, whatever. So we're making this virtual field work. But again, Dr. Jones, his specialty is obstetrics and gynecology. And I introduced him so I know you remember what we said about his experience. He's from Cape Fear Valley Medical Center, course director, obstetrics and gynecology, Methodist University PA program. He's also chairman of the Department of Obstetrics and Gynecology, Cape Fear Valley Medical Center. He's the owner and manager, staff physician, Jones Center for Women's Health. And he's medical practice, obstetrics, gynecology. And you'll find this interesting, as mentioned, provides full spectrum of obstetrics and gynecology. And note this, performed over 9,000 deliveries and 4,500 gynae surgeries of all sorts. So Dr. Jones, you have our attention, and I can say firsthand, having heard your presentations previously, we're in for a treat. So we'll turn it over now to Dr. Michael Jones.
All right, hello everyone. My name is Michael Jones. I'm a community obstetrician in a town, Fayetteville, North Carolina. So I'm not at a university hospital. I'm a real guy down in the trenches. I had the privilege of delivering 9 babies yesterday on call. So if I seem tired, that's why. But the fun part about this is that I'll be talking about some things that aren't just restricted to a university setting or a research setting, but this is stuff that anybody in any situation throughout the US and really most of the world can do to reduce or eliminate the use of blood when we're talking about cesarean deliveries. Okay. So let me get my screen shared here and we'll get going. Okay, so why should we be worried or why should we care about blood loss at cesarean? Because C-section is now the most common surgery in the US and actually worldwide. 1 of the 3 births in the United States is by C-section. My batting average was better yesterday. I only had 1 C-section out of those 9, but it's not uncommon for me to have 3 or 4 in a given day. And nationwide, it's 1.15 million in this country. The average blood loss at a C-section is about, we call it 600 frequently. It's probably higher than that, probably about 750 cc's. And remember, like Dr. Waters said, most pregnant women are going to come in to that delivery with about 4.5 to 5 liters as total blood volume. So they're losing a lot. Nationwide, if you look at stats for transfusions, the numbers range from anywhere from 3.1% to as high as 20%. At our hospital, it's roughly about 4% transfusion rate, which is a lot. We do about 1,000 sections or so in our hospital every year. So that's 40 plus people that are getting blood after C-sections, and massive transfusions occur about 1%. So it's not an uncommon phenomenon, and it's in some sense, in some situations, largely preventable. Rates of transfusion are increasing over time. The reason for that is because the C-section rate itself is increasing over time, and the high-risk situations like placenta previa, placenta accreta, placenta procreta, all of these things are also increasing, largely secondary to the high C-section rate. And again, as Dr. Waters also mentioned, transfusion is not a benign situation. It's associated with morbidity, whether that be circulatory overload, immune suppression, and other phenomena, development of antibodies. And of course, as we all know, there are a number of patients that have clinical or religious objections to transfusions. So we want to be cognizant of the need to develop a standardized technique that lowers our risk of having blood necessary for cesarean and post-cesarean care. Historically, many physicians' perception with patient blood management has kind of been, well, we'll see what happens. We'll do what we usually do, and hopefully you won't need blood. That people get that a lot. Witnesses get that a lot when they see the doctor. But realistically, as you all know, patient blood management is a sophisticated sort of three-legged stool where we want to make sure we take care of the patient prior to surgery by optimizing their blood count, in the operating room by controlling blood loss whenever possible, and then outside the operating room. And there's two phases of that with postpartum women. One is being alert and managing postpartum hemorrhage, and the other is regenerating blood and tolerating anemia. And if you're lucky enough to be in a well-equipped hospital, a multidisciplinary team approach is helpful, whether that involves the surgeon, anesthesia, hematology, the nursing staff. All of these things are necessary to have an effective blood management strategy. A lot of the work that goes into avoiding transfusion in these parturients is avoiding anemia. In our community, we have residents at our hospital, and one of them did a screen for anemia project. And our rate of anemia at the time a woman presents for delivery in our community is 30%. 30% of our women have a hemoglobin of less than 10 when they show up to deliver. That is the same as Afghanistan. It's terrible. We have a young community. They eat poorly. They've got bad nutrition, and there's some exposure or some prevalence of thalassemia and other hemoglobinopathies in our community, as we have a relatively high African-American community. But this is a critical area where we can intervene to avoid starting behind the 8 ball with anemic patients. So we screen for anemia at the first visit, and we've encouraged everybody in our community to do that, as well as 28-week visits, because that's when the hemoglobin tends to nadir in parturient or gravida, and that's when you can intervene. So pregnant woman starts her pregnancy with 4 liters of blood. Typically, she's going to expand to about 5 liters of blood to compensate for the uterine bed, which is now getting 20% of the blood instead of 1% when she's not pregnant. So that needs an extra liter of blood, and also to compensate for the blood loss that's anticipated at delivery. That extra blood needs not only plasma, but also extra red cells, which requires 1 gram of elemental iron throughout the pregnancy or so. A typical woman gets about 17 milligrams of iron from her diet. A typical prenatal vitamin has 27 milligrams in it. It's not enough. So to Dr. Waters' point, oral iron supplementation is critical. Oral iron is not absorbed all that well. So I really, and I'm not a grits and granola obstetrician, but I really harp on my patients, please eat iron-rich food. We give them a list, find something on this that you like to eat, because iron-rich food has both the iron and the ferrous form that's more easily absorbed. It also has the folic acid, and if it's a meat product, B12, so that these are the elements necessary to generate red cells. After the first trimester, we do encourage separate oral iron supplementation for the prenatal vitamin, because the prenatal vitamin just have enough. It would be too big and too unpleasant. And we have a low threshold for putting people in the IV infusion clinic. So if you come in at your 28-week visit and your hemoglobin is less than 10, you're going to get referred for IV iron outpatient. Frequently we can use EPO. The real advantage of EPO is not so much that you get more hemoglobin, but really that it's faster. So typically, if we identified our 28 visit, we just use IV iron. If we have someone who we identify at 34, 35 weeks, and they're still anemic, that's when we kick the EPO in, or post-operatively. And there are many iron formulations. There used to be a tremendous reluctance to use IV iron, as Dr. Waters mentioned, because of concerns of anaphylaxis. But the new iron formulations, whether it's Injectafer, Monoferric, or Venofer, they are not prone to anaphylactic reactions nearly as often as the old iron dextran. So I think we can use those safely. Injectafer and Monoferric are wonderful because they have really high doses of iron. Typically, Injectafer has 750 milligrams, Monoferric 1,000 milligrams. They're just more expensive. So if you want to cut costs, you can use Venofer, which is anywhere between 240 milligrams of elemental iron. You'll just need more doses. But these are excellent opportunities to try to get your hemoglobin up to 11, 12, 13 prior to starting your cesarean. Okay. The next thing that we like to do is make sure that, to the extent possible, we can identify patients who are at risk of intrapartum or postpartum bleeding. And there are a number of scores that have been developed by A1 or ACOG that do a great job of that. And so one thing we do in our unit is every time someone presents for a scheduled cesarean or in labor, they get a hemorrhage score. We use the A1 score. It's in our electronic medical record. They're rated green, yellow, or red. It's right there on the labor chalkboard. And so everybody sees it. And each of those triggers a nurse-driven protocol to have medications available. If they're low risk green, we typically just have Cytotec available. If they're yellow, we have Cytotec and Hemabate and Methergen. And if they're red, we typically have all those things plus the entire hemorrhage cart, which I'll discuss a little bit later. Okay. One of the other big principles is that early recognition and aggressive management of postpartum hemorrhage is critical. Deny and delay kills people from hemorrhage. So as tempting as it is to want to believe that your patient isn't bleeding as bad as the nurse says, you have to really stay on top of it. After delivery, high tolerance of anemia, particularly in stable, otherwise healthy, non-bleeding patients, is critical. Most of our patients are that way. We don't need to have some magical number transfusion threshold. This has been one of the most difficult culture changes in our hospital. Our residents still abide by, well, they're hemoglobin 7, they need to be transfused, and we're working through the fact that the morbidity and mortality doesn't start increasing in patients until hemoglobin is really less than 5. And the other thing that I think is critical is make it easy for the doctors to do the right thing and the nurses to do the right thing. Have an inpatient anemia protocol, click the button on the computer or get the order sheet out so that everybody knows right there at their fingertips, okay, I have my erythropoietin, I have my Venofer, I have my B12, my vitamin C, etc. I just have to check the boxes and my patient gets what they need. I don't have to think about it. Okay. So this is an example of hemorrhage scoring. I have the ACOG hemorrhage scoring sheet on the side. And what hemorrhage scoring does is it allows you to prepare for a hemorrhage to the extent that that's possible. Most hemorrhages, or many, are going to be unpredictable, but to the extent that you can see it coming, you can start marshaling your resources. Okay, because again, if we're going to engage in blood conservation therapy, timely recognition and aggressive management is essential. These people bleed heavy and fast, and if you're trying to avoid transfusion, you have to get on top of it as quickly as possible. Okay. Certain things you might need besides just the medicines, particularly for these high-risk people with previous, accretus, fibroids, DIC, etc., or take back, bring another surgeon. There's no shame in that. Because some of the things you have to do to get these bleeding controlled is technically, you know, outside of most people's wheelhouse. You know, uterine devascularization is not an uncommon procedure. Cesarean hysterectomy, again, out of those 9,000 deliveries, I've probably done maybe 5 or 10 of those, which is more than most people, but still not a whole lot. So it's good to have an experienced surgeon with you. And hypogastric artery ligation, I've had the pleasure of only having to do that once. So again, nice to have another person with you that can help you if the patient's bleeding badly and you have to do a relatively complex procedure to get them to quit bleeding. Cell salvage, critical. And also the role of interventional radiology can't be understated. They are increasingly useful for helping us manage postpartum hemorrhage. Preoperatively, we can put balloons in either the hypogastric arteries or in the aorta, like the Roboa device. Or if the patient is bleeding postpartum or post-op, a uterine artery embolization can be performed that prevents the need for relaparotomy and can control bleeding in a controlled situation. So what is a C-section? 3 things: laparotomy, hysterotomy, and extraction of live fetus. So sizing the abdomen, sizing the uterus, getting the baby out. And you can bleed any of these points. Okay, so the first thing to think about is the things that really aren't necessarily in my wheelhouse, but this is Dr. Waters' game here. When you place a spinal, typically the order of things is that spinal is placed, and prior to placing the spinal, there's going to be some drop in blood pressure. The patient is front-loaded with fluid. Okay, you can actually do acute normovolemic hemolution prior to that if the patient finds that acceptable, where you can extract some blood, then tank up the patient with fluid, have them bleed the dilute blood out, and then replace the loss rather than with IV fluid, replace it with patient's own blood. Keep the patient warm. Have the room warm. Surgeons like the room cold because you've got all this gown and what have you on, but the room should be warm both for the baby and for the patient. Put the baby on the patient. That keeps her warm too. The role of tranexamic acid historically has been used as a hemorrhage mitigation post-op, but now there's reasonably good data from meta-analyses that prophylactic administration of tranexamic acid can be used safely to reduce blood loss of cesarean without increasing the risk of thrombosis. So I certainly do this routinely with my witness patients. I think as the data accumulates, it's probably going to become a routine practice for all of my patients. And then all of our patients get oxytocin to help mitigate uterine atony. And then you could even take it a step further and give the patient rectal misoprostol to help, again, mitigate uterine atony so the patient doesn't have postoperative vaginal bleeding. Okay, how to make the incision. So historically, we have used fan steel incision. It's nice and low, it's cosmetic, it's cute, and it's a larger incision, and it's made sharply. We like to use a transverse incision of some sort because if you do a midline, it's ugly, it's painful, and there's a higher risk of dehiscence and hernia. So you're not going to get buy-in to do a midline incision on most patients unless it's a morbidly obese patient or there's another reason to do it. If you're going to do a transverse laparotomy, a Joel Cohen type incision is now preferred. That's a smaller incision than a fan steel incision, and it's higher up off the mons, so you get less of that mons bleeding. There are a number of perforating vessels, superficial epigastrics, and others that tend to populate down this mons area where the fan steel incision is. And so I avoid that now, particularly in a patient that's concerned about blood loss. We do the Joel Cohen method. It's a smaller incision, doesn't go out quite as far laterally, and it's developed bluntly so that the vessels kind of stretch and get out of the way as opposed to cutting them. with electrosurgical device or with sharp instruments. Bluntly, that is develop the fascia, and then you want to stretch cephalocaudad to get the rectus fascia off the muscle. Again, that avoids a number of the perforating vessels that tend to get interrupted when you develop the transverse incision the traditional way. Okay. We also get into the peritoneal cavity bluntly instead of sharply, again, avoiding blood vessels. This doesn't sound like a big deal to most people that do C-sections because typically the blood loss is at the hysterotomy, but when we have relaparotomies, we take people back more or frequently, it's not bleeding from the uterus like everybody's worried about. It's bleeding in the incision at the rectus sheath because a lot of times people will hit a perforator on the way in, it'll spasm, they'll ignore it, or they won't notice it, and then that will become a rectus sheath hematoma, which will require, and it's pretty amazing how much people can bleed from those rectus muscles, liters of blood. So developing the laparotomy appropriately and inspecting it on the way out is critical to avoiding unnecessary blood loss. So that's getting in the belly. Okay. Hysterotomy, that's getting into the uterus. Okay. And in most cases, we're going to do a low transverse hysterotomy. There's a couple of reasons for that. Number one is that the lower uterine segment and cervix are considerably less muscular and less vascular than the uterine fundus. So you encounter less bleeding going in. Remember, 20% of the patient's cardiac output is going to her uterus. When you cut it open, that's a liter every minute. When you cut it open and you leave it open, if you're in the fundus, you're going to bleed that almost that entire liter or some large fraction of it. You only have a little bit of time to get it closed and you have to control it. So if you go in a less vascular area, so much the better. I recommend you score the incision with the knife and then get in the uterine cavity bluntly. There's a couple of reasons for that. One is that you tend to avoid interrupting blood vessels. And then secondarily, won't cut the baby. And then historically, I was always taught to open up the uterus or the uterine incision side to side. The problem with that is that you can extend out laterally, and guess what's out laterally? The ureter and the uterine artery and vein. To get into the uterine artery and vein, that's each of those vessels, 500 cc's of blood every minute. It's a lot of bleeding and a lot of trouble to close. So rather than going laterally, if you can extend the incision up and down, that will allow the incision to stretch along the fibers. It'll still get a nice transverse opening for the baby to come out, but you are much less likely to get into the uterine vessels laterally. So the cephalocaudad approach, I think, is superior from a blood loss perspective for sure. You can close the uterus either in 1 layer or 2, whatever it takes to make it quit bleeding. And this one is always hard for me. You should wait for the placenta to separate spontaneously. I like to move along during my C-sections, but realistically, there's considerable data that says that there's less infection and less blood loss if you allow the placenta to separate spontaneously, allow those spiral arteries in the myometrium to contract rather than just sort of manually shearing it off and taking it out, where you're going to have considerably more bleeding, particularly if it doesn't come off clean. So once the baby's out, hold pressure on the uterus, massage the fundus, allow the placenta to spontaneously deliver. Okay. The laparotomy accounts for 30% of the bleeding. If you take someone back, hysterotomy bleeding is 40%. So you have to inspect the hysterotomy, make sure it's dry before you leave out, particularly any lateral extensions you might have. Okay. How do we get the head out? Well, usually it's not that big a deal. If the head is right at the lower uterine segment, a lot of times a simple manual elevation is able to be done. And what you're trying to avoid, again, when you get the baby out, is you're trying to avoid an extension of the hysterotomy, either caudad or worse yet, lateral, where it can get into vein or vessels that are very difficult to control. So if the person is a repeat cesarean and the uterus is not, it's not very muscular anymore, it's very thin, sticking your hand in there, especially if it's big as mine, can cause an extension. So you can either use a head extractor or the forceps blade. That's helpful to get the baby out without making an extension. The other time that extensions are big trouble is when the head is deeply impacted. So maybe the patient's been pushing for an hour or two, the head's very low. If you get the baby out in the usual way and reach down, try to get that baby out from your usual hysterotomy, you're likely to have that very thin and sometimes infected lowering segment to extend either inferiorly or laterally into vessels that are difficult to control. So there are a couple of techniques that can be used and with a deeply impacted head. What we frequently do at our hospitals, we have a nurse put her hand in, push the baby's head up to an area that it's much safer to extract. That's the hand from below technique. The other thing you can do is that rather than trying to get the head, which is so deeply impacted, is you can reach up and to grab the legs and do what's called an internal pedalic version, where you basically do a reverse breech extraction. Grab the legs, pull it on down, the head will naturally elevate when you do that, and that will keep your hand from leaning back on the hysterotomy and extending the hysterotomy into a situation where you're going to have bleeding. So certainly very wise to be cognizant of that to avoid unnecessary bleeding. Okay. Cell salvage, Dr. Waters, I think, went into this in great detail. It is a matter of conscience among Jehovah's Witnesses, regardless of whether or not you have a continuous circuit or a discontinuous circuit. And as he mentioned, there's been controversy in the anesthetic literature and the hematologic literature about whether or not it's safe to use a cell salvage device when there's infection. Is it safe to use it in the presence of amniotic fluid? Because we don't want someone to have sepsis. We don't want someone to have an amniotic fluid embolism. It turns out that the data, and he's mentioned this too, really supports the fact that you can use a cell saver even in the presence of infection or obstetrical situation, or even malignancy for that matter, which is not ordinarily an issue for us. But there's not been a reported case of amniotic fluid embolism with the cell salvage device so far. It does not appear that there's an enhanced risk, even in a surgery like a C-section, which is what's called clean contaminated. You enter into the uterus, it's not a sterile organ, particularly if someone's been laboring for a while. But all the same, you're not gonna put that patient at risk of sepsis. So it's safe to use. We typically use something called a double setup. So we have a dirty suction. So when I get into the uterus and I break the water, I have my dirty suction suck up all that amniotic fluid to sort of lower the risk of putting amniotic fluid and amniotic contamination in the cell salvage collection. That's not strictly necessary, but I find it helpful. Same with leukocyte depletion filters. We use those, but again, there's no real data that says you have to. So if you don't have one, doesn't mean you can't use a cell salvage device. And I find if you get kickback from your anesthesia colleagues, ACOG just had in August of 2021, an anemia and pregnancy guideline that says specifically the use of intraoperative cell salvage in obstetrics has been shown to be feasible, safe, and potentially effective in reducing the need for transfusion. So we have the blessing of ACOG. I think it's worth using. The one thing I'll say is right now our facility is not like Dr. Waters in that we have only a few perfusionists in our hospital. They're on call. Not everybody knows how to use a set of the cell saver. So again, if you think you're going to need it, you have to assess your facility's ability to pull it together on the spot. But the flip side of that is that if you can make blood conservation a priority at your facility and make cell salvage more available, then this is a useful thing, because although we like to try to predict those patients are going to bleed, we can't always do that. Okay. Early recognition is critical. And historically, we have been bad about that because we use estimated blood loss. There are innumerable studies in the literature, and every surgical specialist show that we are bad at estimating blood loss at every level, whether it's medical students, residents, attendings. We habitually underestimate the amount of blood loss, both at vaginal and at cesarean deliveries. So why do we do it? It's easy enough to actually quantitate it. And so ACOG has really made a point of that as long ago as 2019, that we should be doing QBL, quantitative blood loss. It's not that hard to do. In a vaginal delivery, that means you have calibrated drapes under the buttock. So when she bleeds, you're measuring it right there and weigh the sponges and the clots. Typically, a gram or so of extra weight on the sponge or a gram or so clot translates to roughly 1 milliliter of blood loss. So QBL should be a part of any labor and delivery unit or any cesarean where the institution is serious about managing postpartum hemorrhage with as little blood as possible. We give everybody Pitocin afterwards. And we have a nurse-driven protocol at our hospital where if you lose more than 500 cc's QBL, or after C-section you have more than 500 cc's of vaginal bleeding recovery, they automatically give tranexamic acid. And then they call us. And I can tell you QBL is critical because I'm not always in that hospital. And if the patient calls and says, the patient passed a clot, I might stay in my office and keep seeing patients. If that nurse says, your patient passed a clot and we waited and it's 750 cc's blood loss, I'm going to leave my office and I'm going to go up there and see what's going on with that patient. It really enhances the communication between the nursing staff and the doctors. And as I mentioned before, what kills people, what gets blood transfusions going is deny and delay. And so if the nurse gives accurate information, then you have the good sense not to deny and delay. We have a hemorrhage cart put together too, so that it's easy to access the medicines and the equipment necessary to deal with heavy bleeding. And this can be done anywhere. The hemorrhage cart has Cytotec, Methogen, Hemabate, transexamic acid, and a uterine tamponade balloon. And then finally, what causes postpartum hemorrhage? The 4 T's, right? Uterine tone, retained tissue, coagulopathy, and then trauma. So bring the ultrasound in the room, take a look, make sure there's not any retained tissue inside the uterus, either after a vaginal delivery or even after cesarean. Sometimes you can either have retained tissue or retained clots that need to be evacuated so that the uterus can have satisfactory tone to reduce blood loss. Okay, our hemorrhage cart is essential. It allows us to have quick access to our supplies. It has a refrigerator built into it for things like Hemabate that require refrigeration. Should be properly labeled. And on top of the cart, it has instructions for how to use things like that Bakary balloon, the uterine tamponade balloon, that people might not necessarily be familiar with. And it has a checklist on the top so that everybody's following a prescribed algorithm for managing bleeding that may occur. Okay, and so Dr. Waters referred to the CMQCC hemorrhage protocol. We use that too. And as we implement our management, we stage the patient by QBL. Have they lost 500, 1,000, 1,500? What are we going to do? Okay, this is the exact same slide from Dr. Waters. And I guess what I'm going to emphasize is that you'll see one thing, they are pretty aggressive about putting blood in people, even after a liter of blood loss, which is not clinically necessary. But by the time you get down to stage 3, we're talking about 10 units PRBCs, mass transfusion protocol. That's obviously not a place we want to go with our Jehovah's Witness patients. So the key is that we have to act before the patient has markedly abnormal vital signs and before the patient has 1,500 cc blood loss. And the patient has to be at peace with that, because sometimes definitive management of a hemorrhage, involves things like hysterectomies and other surgical procedures that aren't necessarily the first thing somebody thinks about when they go in the hospital to have a baby. So with our witness patients, I do have to tell them I have to be more aggressive with managing your blood loss, and that may involve definitive surgery like a hysterectomy or uterine artery embolization, that sort of thing that can impair fertility as well. But key is here, stage your blood loss, have a plan of medicine administration, calling in a second surgeon, having an OR available. And again, you have to get that hysterectomy, not at stage 3 when you're doing mass transfusion like you might with a non-witness patient, but really at stage 2, where the patient has lost a liter, but not much more than that. Because by the time she becomes stage 3 and she's had that kind of bleeding, the cycle of hemorrhage begins to spiral. the patient gets acidotic, coagulopathic, and very difficult to control without blood products. So that's the key of this slide here. We really want to start intervening at stage 2. And this is actually an algorithm similar to that was developed by the Watchtower Society. And you'll notice, again, that you move to hysterectomy relatively quickly. So the critical aspects of managing a witness patient or a patient who does not want blood is that you don't want to guess about the blood loss. Have QBL and act quickly. Don't deny and delay. You certainly can give medicines, but really before the patient gets unstable vital signs and coagulopathic, you need to move to surgical management. Surgical management could involve placing a balloon in the uterus, uterine artery embolization, uterine devascularization, B-Lynch compression sutures, or peripartum hysterectomy. The other piece of the pie is that you need to know what your patient is going to accept. Some people will accept cell saver, which is a godsend, and these people that are bleeding heavily. If the patient's coagulopathic, cryoprecipitant can be a great help, but that needs to be obviously discussed with the patient. Same with fibrinogens and recombinant factors. Okay. And that's just the basic cesarean. There, of course, are situations, as Dr. Warner mentioned, that are high risk for significant bleeding. So I told you, typical cesarean, the transfusion rate is roughly 4%. For someone with a previa, the transfusion rate is in the teens. And with someone with a morbidly adherent placenta, it is upwards of 60% in the general population. So with those people, if you have a witness patient, you really have to make a lot of preparations, because if left to standard management, the likelihood that person is going to need a transfusion is 60%. So ideally, if someone is going to have a placenta or a morbidly adherent placenta, you find that out before you go into the operating room. That's not always possible, but again, as part of standard obstetrical care, patients should have an ultrasound. If they've had multiple cesareans and have a previa, you should be suspicious of a accreta. Those people might benefit from an MRI prior to their delivery. Accretas, I know most of you guys know this, or many, obviously. A normal placenta is going to implant above the nidobulk layer of the endometrium so that it separates off cleanly. With accretas, that nidobulk layer is damaged, and so the chorionic villi are invasive into the endometrium below the nidobulk layer where they can't cleanly separate. With accretas and procretas, the villi actually invade into the myometrium, or worse yet, through the myometrium into adjacent organs. And so this information is helpful because, number one, you have a morbidly adherent placenta, it is unlikely to cleanly separate, and your options for management, more often than not, particularly in transfusion avoidant patients, is going to involve a hysterectomy. If you know that going in and you realize that hysterectomy is going to be a bloody procedure, then again, having interventional radiology place a balloon either in the hypogastric arteries or in the aorta can be helpful. Having IR available for postpartum or intrapartum uterine embolization can be helpful. Having a cell saver can be helpful. And particularly if the procreta is present and it invades into the bladder, which is the most common, or the bowel, you may need to have a second surgeon available, such as a urologist or a general surgeon, or just a second pelvic surgeon, so that the procedure can be performed as expeditiously as possible with as minimal blood loss. Have the cell saver available. And one of the other scenarios that comes up is coagulopathies, either DIC from some obstetrical catastrophe like fetal demise, abruption, or amniotic fluid embolism. Those people, you need to deal with the primary problem as quickly as possible, get the patient delivery as quickly as possible, get hematology on board, and then these are the people that you really have to explore the use of cryoprecipitant, fibrinogen, and recombinant factor 7. Remember that if someone loses a lot of blood or has concomitant sepsis, they're likely to become acidotic, have volume issues, and hypothermia. All of those impair coagulation, so they need to be treated along with resuscitating the patient. But To the extent you can be prepared for this, so much the better. We have an OR in our hospital that was designed for aortic valve replacements, but it's got cell salvage and interventional radiology right there in the room. We've asked to borrow it on these people, and that's been a helpful intervention. So if you have something like that available at your hospital, so much the better. Okay, and then finally, now our patient's delivered. Okay. You've done your best to get her tanked up before surgery. You've done a clean surgery. You've managed postpartum hemorrhage, but she's anemic afterwards. What do? We got to maximize the red blood cells she has. Remember, at this point, if her volume is normal, then really our anemia is more about oxygen delivery. And so, to the extent that you can keep her sats above 98%, to limit her activity whenever possible. Of course, difficult with a newborn. Try not to draw too much blood, and then when you do, use pediatric tubes. And finally, really get aggressive about helping her build back her blood. IV iron, erythropoietin, vitamin B12, all helpful. So again, what we do at our hospital is we have a non-blood anemia protocol that all the residents have to do is put inpatient anemia protocol, it pops up, they populate it. And so our uptake of Vinifer has been very, very high at our hospital, almost to the point that the pharmacy called me and they said, you guys spend a lot of money on IV iron. And I said, well, it's better we spend on that than blood. So make it easy, and that's helpful. Okay, so I'm just going to wrap this up. I know we've got a long day here, but remember the 21st edition of Williams Obstetrics says famously that obstetrics is bloody business. When we deliver a baby, blood loss is probably about 750 cc's. And at C-section, our transfusion rate nationwide is about 4%. Same in our hospital. We're working on getting that down. But preparation, both before the surgery, having a standardized technique, and then managing them afterwards can reduce that significantly. Maximize your hemoglobin prior to delivery. Check early, check often, check at the beginning, check at 28 weeks. Get people into IV iron clinics as aggressively as you can. Score everybody when they show up at the hospital for the likelihood of hemorrhage, and marshal your resources as you can. Remember that involves not only medicine, but equipment, anesthesia consults, second pelvic surgeon if necessary. All right. We teach our residents try to use a standard technique for minimal blood loss during cesarean, and we just don't limit that to witness patients. Everybody gets a Joel Cohen incision, a blunt uterine entry with cephalocaudate impression, so that they are used to a technique that has lower blood loss and manual expression of the placenta. All right, and the number one culprit, and CMQCC emphasizes this a great deal, but the number one culprit for death from hemorrhage and morbidity from hemorrhage and transfusion is deny and delay. So blood loss should be quantified, not estimated, and you should have hemorrhage kit and cart assembled, available, and stocked, so that when things go bad, even unexpectedly, they can be handled quickly, so that there's a minimum morbidity from blood loss. Every labor and delivery unit should have a stepwise postpartum hemorrhage management protocol of some sort. And if you have a patient that's bloodless, you want to make sure that you intervene surgically and definitively prior to you getting the class 3 shock. So waiting until the patient's blood pressure drops to 80s over 40s, or pulse is 140, where you've got 1.5 liters blood loss, is not really appropriate for a Jehovah's Witness. Should intervene a lot quicker than that. Get them to the OR, have salvage available if it is acceptable to the patient. And then finally, don't freak out because the patient's blood count is 5. That's not, it should not be a transfusion trigger necessarily. Many patients, as Dr. Waters mentioned, can have a hemoglobin 2, 3, and do perfectly fine. You just need to encourage their bone marrow to correct that problem as quickly as possible with iron, oral B12, folate, epigen. Okay, and I have some resources on the slide if anybody's interested where I got some of this information from. But point being is that a lot of the more common scenarios where transfusions are currently being employed in our country, they're really avoidable at any given medical facility or hospital in the country. And it doesn't necessarily require advanced technology to serve our non-blood patients. All right, thank you for listening.
Dr. Jones, thank you very much.
Yeah, thank you very, very much.
Very informative, and there's so many appreciative comments in the chat box there. Very informative, very helpful. I knew we would not be disappointed, of course, on the entire program this morning. So we really appreciate that. We've been granted permission to go just a bit over time, so we have some Q&A for both Dr. Waters and Dr. Jones. We really appreciate both. I'll start with, let's see, a couple of questions earlier for Dr. Waters first. One had to do with, which I think both Dr. Jones and Dr. Waters touched on, had to do with iron supplementation. And I just lost the question. But can we have an observation, Dr. Waters, on iron supplementation in the pregnant patient? I'm sorry, in the anemic patient.
I'm sorry, I'm not sure I'm following the question. Iron supplementation is something that we don't do a very good job at, and patients somewhat hamper us because they don't follow oral iron recommendations. So I think IV iron should be used a little more aggressively than what has been the standard practice. And it's cheap, you know, relative to other therapies. And it just doesn't make sense to me that a $9 drug is not used more widespread and more effectively, especially when you look at the side effects of oral iron. But I'm not sure I got to the heart of the question.
And I apologize, I found it. Let me get more specific, my apologies. It says, question is around when the need to get iron levels up. We look to IV iron when time is limited, but will iron supplements be as effective over a longer period of time, or is it stored differently in the body versus active iron where heme protein is present, as is the case with lean red meat?
Well, I think the major problem with iron is patients don't take it. And Dr. Jones can probably comment better on that than I can, but I believe the rates of compliance is around 25%. So it's very low. But I think that in pregnancy, the vast majority of women that present with hemoglobins less than 11, they're all iron deficient. And I think even patients that are presenting with hemoglobins of 11 are probably iron deficient also. So I think, you know, as a public health issue, we need to be much more aggressive with iron replenishment.
Yeah, I would agree. And I will tell you that in my experience, most people find the oral iron pretty noxious. It tastes terrible, gets them constipated. And I've seen some of the suggestions pop up on the chat, and they're very accurate. For one thing, I think we've kind of beat people with this idea that you have to take it twice a day. Really, the data shows that every other day is probably quite sufficient because you just really don't absorb the iron in the formulation that is in tablets very well. And so that's what gets people so constipated and have all the abdominal pain. And trust you me, a pregnant woman with abdominal pain and constipation is not a pleasant person. So I think if we can kind of relax a little bit on the uptake, that's critical. And the other thing is I really try to get them, and this is where peer pressure comes in, get them with their friend, get them with their mother and say, can you guys be food buddies and find some iron-rich food that you guys like to eat together, whether it be, you know, I said raisins or green or salads. I said, you know, this is your time. A little peer pressure, and even from the other pregnant women, we get together and kind of do a group dietary chat and say, hey, let's all eat better. You know, McDonald's not necessarily wrong, you know, here and there, but please make sure you get some red meats and some and vegetables, because ultimately that's what's going to be a lot easier tolerated than the tablets.
Yes, thank you. Very helpful. And I guess a question for either, how tolerable, this is anonymous attendee, how tolerable is acute normovolemic hemodilution for the pregnant woman?
Well, I can touch on that. It's not well studied in terms of the safety. There's probably 35 cases in the literature of it having been done. So I think with cell salvage, you can basically get the same bang for the buck. And I've done a lot of ANH, and oftentimes it's a waste of time because you can spend a lot of effort trying to harvest blood and then just not need it. So I'm not a big advocate for it for those two reasons.
Yeah, and I think it is very situational. If you're in an institution where cell salvage is readily available, it's the way to go. Under other circumstances, you may have to consider doing an ANH.
To both of you, let me put this out there because we are having a few questions that are kind of talking about the different preparations of iron. And to that end, particularly in the obstetric patient, do you think some of the uncertainty or of the non-use of the IV iron preparations are because the newer preparations perhaps do not have the category of safety that comes with other drug recommendations for the pregnant patient? Is that an issue? Or are the ferric carboxymaltoses, et cetera, the isomaltosides been approved category, B or whatever that iron sucrose typically is for these ladies that might need that?
Go ahead.
Yeah, in my experience, it's mostly financial, honestly. Vinifer is probably about $200 or so for an infusion. When you get to, we've been almost forbidden to use Injectafer or Monoferric in the hospital, but outside the hospital outpatient, we can get 403B pricing, which is a little bit, 403B, which is a bit cheaper. So a lot of it is negotiating the financial piece of it all. And we've gotten so frustrated, we've almost decided that we were thinking about doing our own infusions in our own office because it was getting so difficult to get people in outpatient infusion clinics. With COVID, the other thing was that the outpatient infusion clinics got taken over with the monoclonal antibodies and a few other things.
And convalescent plasma, et cetera.
Exactly, they got kind of tricky. So now that that's no longer really happening, they're redirecting their infusion clinics away from that and giving us more chairs. But as you know, it's hard to come by nurses and everything else. So we've even investigated doing it in our own office, honestly.
So John, is that your feeling too? It's not really a fear of the safety in these pregnant women for use. It's really more of that financial and what's available.
Yeah, there's a misperception that it's expensive. And we also have the same problem, with the number of chairs in our infusion clinics. We have 14 infusion centers and they pretty much are inundated with patients, getting other sorts of therapy. So IV iron, takes a back seat in most cases.
Thank you. If I may just combine a question, and then we're going to turn it over to Carolyn for time's sake. But we've had a couple of questions regarding low resource settings and the efficacy of options. There's one question very specific. I'll read it. It says, where cell salvage is not available, what are your thoughts on whole blood intraoperative autotransfusion for PPH, and specifically if a patient has undergone a C-section that needs to be reopened for uncontrolled bleeding? So putting that question out there, but then broadening it to low resource settings in general. Observations, comments from John and Michael, please.
Well, as I mentioned, unwashed cell salvage was first performed in 1874, and it was the primary mechanism of transfusing patients for almost 70 years until modern blood banking was invented. So, I think it can be done safely, and we've done it routinely up until relatively recently in cardiac surgery and in orthopedic surgery, where surgical drains have been used to collect blood and then just reinfuse it. nothing's changed, except a perception. So, I mean, I think in a low resource setting, I mean, you can go back to, 1900 and do what was done there. There also is this company, Sisu Medical, that is providing a device that looks like a giant syringe that has a filter built within it that can collect the blood and then basically put it into a transfusion bag. It was a device that was invented by one of our graduate students here at Pitt, who's also the daughter of one of our CRNAs, but she's been trialing it all over Africa, and it seems to work.
Amazing.
Yeah.
Wow. Well, so because of time, thank you all very much. So many good questions, great participation, and for all of our speakers, we really, really appreciate all this information. It's so important, especially as we celebrate this particular Bloodless Medicine Day, as well as this entire week. And also as we expand the range in these particular patients, where we're talking about moms and babies. So really greatly appreciated and very honored to have you all here. I do know that Dr. Soro had mentioned earlier on that Professor Itam wanted to come on. He is now with us. So I wanted to give him an opportunity to make some comments too, as we kind of round out our day, and then we'll start to look forward to the rest of this week. So Dr. Itam, if you are on, please take the floor.
Yes. I'm lucky to be able to join you at this time into prevention and postpartum hemorrhage now. And it's been great having the knowledge of bloodless medicine. To help me save the life of
I think maybe, Natalie, we're having some problems.
Yeah, it doesn't seem his connection is clear enough to be able to hear his audio. He could maybe turn his video off. That could maybe aid his audio, if you want him to try that.
Yes, yes. Dr. Itam, if you could, we're having trouble hearing you. And so our technical support is suggesting perhaps take off the video and then try to unmute again, and we'll see if that works better. I think maybe perhaps.
Yeah, he's not coming back through.
Not coming back through. Dr. Soro, would you like to just say a few final words?
Oh yeah, I think you can go on. Okay, maybe change.
Here he is. He has another connection.
Okay, good.
So, Prof, are you there? We're still waiting for you. Looks like you've changed your device.
I don't think I can hear you. Thank you, Dr. Soro. I've listened carefully to the discussion, but I just want to say a general thing about this bloodless medicine. Our greatest problem is culture. Our patients and their relations think that have not been able to accept the theory and evidence-based positive results for not using blood. And our colleagues still keep cross-matching, grouping cross-matching blood and keeping for every cesarean section, mammectomies, hysterectomies. But I think with time, the theory and benefits of bloodless medicine will become obvious. People will learn the techniques carefully, and accept the benefit. It is future and it has come to stay. So I think with continuous persuasions based with evidence-based, and for those of us who work in the rural areas and economically depressed areas, where blood is becoming very expensive, it will be more obvious to our patients that bloodless medicine is the way. So let us not despair. Let those of us who are convinced and believe in it continue to use the best practices for operating procedures. And then with time, people will see that it works. Thank you.
Thank you, Professor, very much. I think we all do realize this is important, and in patient care, and really does, as everyone has been emphasizing, really provides for better outcomes. And at the end of the day, that's what we all do, right? We come to work every day wanting to help our patients and to be able to see that through. So to everybody, and Dr. Osuro, any final comments from you? And if not, we will sign off and we'll see everyone tomorrow.
So I just want to say thank you very much to everyone, the speakers, the panelists, the audience. And I'd like to preview tomorrow's program a bit, unless you're going to do that. Caroline, are you going to do that?
No, why don't you do that? That would be great.
Okay, all right. So tomorrow is Tuesday, May 17th. Natalie, do you have it open?
I can do in 1 second.
Okay, you could screen it, please. So tomorrow we have 2 talks. One of them is going to highlight bloodless cesarean section techniques in a low resource setting. Yes, so that is going to be by Dr. Okon, who is a consultant obstetrician and gynecologist in the University of Calabar Teaching Hospital. And then the second talk is going to be by one of the great pillars of bloodless medicine and surgery, that is Dr. Arya Shanda. He will be talking on minimizing blood loss, a key pillar in bloodless surgery. And then we'll also be showing in between and at the end, some very interesting bloodless medicine and surgery videos. Natalie will be screening for us. So that's all I have, Caroline. Thank you very much.
Great. Thanks to everyone that's been online today. Continue this celebration with us this week, and we will see you tomorrow at the same time. If anyone was having problems with logging back in, or things that happened to me, just retry, and we hope that everyone gets connected tomorrow. So talk to you then, and happy Bloodless Medicine and Surgery Week.
Thank you, Carolyn. Thank you, everyone.
Okay. Bye. Thanks, Kev. Bye.
Good night, all.
Good night.
Thank you.
Excellent start, Nat. Turned out very well.
Thank you for your excellent moderation. Thank you to all speakers. And Natalie, when you're done, you're free to sign out.
See you tomorrow. Thank you.
Thank you so much. See you tomorrow.
Bye-bye. Oh, Natalie, I'm just seeing your question here. Yeah, I guess we have more days ahead, so we'll take note of these things and answer them subsequently.
Perfect.
I think she also
Okay,
missed
sounds
the
good.
question. Dr. Soro, you left out my question.
Yeah, so I wasn't the one in charge. I was just your humble servant here. So, but like I said, we still have 5 more days. So we can still have questions again. Anybody whose question was not answered.
Very good. Okay, see you tomorrow.
All right.
Okay. All right.